All right, welcome everyone. Thanks for attending in person. We've got a great group of presentations for you today. I'd like to extend a thank you to the Sanford Burnham Prebys Medical Discovery Institute for once again allowing us to meet here in person in their auditorium. We've gotten some extra help this month from the IT staff. It's been greatly appreciated. The IPCSG principals, as you may know, are Bill Lewis, our president, who also does the newsletter summaries, Jean Van Vliet, our director and treasurer, Steve Pendergast, our secretary and newsletter editor, Bill Manning, director and videographer, myself, Aaron Lamb, and John Tassi, our webmaster. And of course, there's you, well more than 900 members now. And everyone can be a volunteer. You can be too. How many people are new here today that this is their first meeting? Thanks for attending. Thank you. 4 people, I believe. Hopefully each of you hopefully received a profile form. Please do, of course, read through all that, but please fill out and turn in the cover sheet before you leave, and that will help us to contact you in the next week to see what we can do to help out further. There's also an information kit in there containing a list of articles and books. And as I said, there'll be a welcome call. I'm going to skip through a little bit of our usual, hands up slides today since we have so many presentations today. But one thing I'd like to emphasize is that, just because you might have been recently diagnosed with prostate cancer, it doesn't mean that death is imminent or anything. There are people in this audience that attend this meeting that have been, battling their, pursuing their own treatment for 20 years with their own prostate cancer. So there are a lot of different treatments available. There's a lot of people in this audience that can provide you insight into the treatments that they received, whether it was surgery, radiation, chemotherapy, other advanced treatments that are changing all the time. And we encourage you to get the latest information, not just from the principals here, but other people in the audience. So our support to you comes in the form of our website, www.ipcsg.org, that I hope you've all visited. There you can find all the newsletters and be able to contact us via email. The newsletters are available on the website. You should be getting emails with those, and we can send paper copies if requested. The monthly meetings, of course, are on the 3rd Saturdays of every month, except December. And hotline numbers, which you can also find these numbers on the website. Jean, Bill, and Sharon have shared their phone numbers, and they are looking forward to your calls to help answer any questions. In particular, Sharon has offered for fielding any questions for women, family, and caregivers. And of course, we do need volunteers. We need people to suggest and recruit new speakers, share your experience, and please just contact us to let us know if you'd be willing to tell your story or help out in any way. So as a reminder, our support group purpose is we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We're a group of experienced participants, but we are not medical professionals, and any sharing by anyone of our group may not be a substitute for your own medical counsel. And we do need your support. We are a 501c3 nonprofit organization. Donations are tax deductible, and why don't we pass around the baskets. We certainly do appreciate the donations that everybody gives, not just here in the audience, but we also receive quite a few checks in the mail that are beyond generous. Thank you so much for your support. We have no medical or religious affiliations, but our largest costs include the website, advertising, and mailings. So please do make a donation, either here today or online via PayPal, or by sending a check to the address that you see there. And of course, that address is available on the website as well. So next month, we're going to have our member roundtable, and we've gotten Daryl Dixon, Richard Schaefer, and I believe we're finalizing Dan Petty to be sharing their experiences. This is a fantastic time to really hear the details of another patient and see what decisions they may have made, what their complete journey was. I mean, for me, it just so happened that I attended a member roundtable as my first IPCSG meeting, and I was paranoid at the time. I had not yet seen Dr. Rose, but I knew I'd be headed for something like radiation, and I was able to actually, I think it was Bill Bailey, our librarian. He was giving his background, and I could say, wow, you know, this is the same course of my PSA. You know, I also had surgery, and I saw what his future treatment had been, then in his past, future for me, and he was fine, and it was very reassuring to see that I was going to come out fine on the other end. However, for today, we have representatives from UCSD's Radiation Medicine and Applied Sciences Department. We have Dr. A.J. Mundt, the professor and department chair. My favorite, Dr. Brent Rose, assistant professor, and I say favorite because I'm wearing my fan shirt. So my sister had this made. Been there, fried that, if you can't read it from there. She gave me that on my last day of radiation with Dr. Rose. We have Dr. Tyler Seibert, and online joining us today is Dr. Carl Rossi from the California Proton Treatment Center. And I refer to these guys as Dr. Mundt and the Rad MDs, you know, as if they were a band. And I can't speak personally for all of them, but I got to say that I'm not sure how Dr. Rose is on the drum set, but his laser light show really kills cancer. So with that, I'm going to turn it over to Dr. Mundt. What's that? I just heard something, sorry. I hope that was, let's see, which one is, I gotta see which one this is again. No. That one's yours, okay, sorry about that. And if you want, there is a,
okay,
hang on, something is repeating here. Getting some feedback. Testing? All right, okay, feedback's gone. Yeah, you can advance and go back, but laser pointer as well, or just.
Great. Well, good morning, and for people here and to the video people, I know a lot of people watch the videos, which is really, I think, a wonderful tool. And this updates us yearly. This started back, Gene and Lyle and others know, we decided to do like a yearly update. And I think it's an exciting thing because there's like new things that happen all the time, and it sort of puts this into perspective. We're one of the pillars of the treatment of prostate cancer, so we can just take a look at a potpourri of things that involve radiation, and all three of us are going to point out, four of us, sorry, are pointing out new things that are happening in the field. So I invited this little different the group today. It's Brent Rose, Carl Rossi via the wonderful world of the internet. He's up in his home in Oregon on the weekends, and then Tyler Seibert as well, and I'll introduce each one of them when we come to it. So I'm going to give a short little intro of just sort of terminology and what is radiation, and just to get some of the things started. So when they talk, you'll know some of the lingo, because doctors like lingo, unfortunately, and it can be confusing when people start using abbreviations and stuff like that. So I just want to lay the groundwork for some of that. We're going to start with Dr. Rose, who's going to talk about his perspectives and sort of what he looks at when he's talking to a patient about radiation. So I thought that would be a good start. Dr. Seibert has a PhD in imaging, and so he focuses a lot on the use of advanced imaging, MRI, and other techniques to augment and improve how radiation is delivered and works. Dr. Rossi, of course, is he's the lead prostate radiation oncologist at the Proton Center, and he's a member of our department, and he is a world expert on proton therapy for prostate, so he'll be talking about that. And then I want to leave time for sort of a general roundtable where the four of us will just take general questions about your case or things you worry about or anything you want, things you've heard about radiation and you want to have clarity on. So these are the four people, and so we'll go one by one when I introduce them before their talks. But that's not our whole group. So the Rad Onc members for my department is stretched all around San Diego and beyond. And I'm sad to say Dr. Eink, he married a very much younger spouse, and so he's following off to medical school. At age 60, he's starting his career again in Kansas. And I think he's going to have a great new career, but I wish he had continued his career here. But family takes precedence, as you all know, over professional life. But the rest of us, many of you may have been treated by other members of our radiation family at different places, and they work at different centers. And so many of us work in La Jolla. Dr. Rossi and Dr. Rose are at the Proton Center. So the exciting thing about, I think, our group, and we have all these different people, and one thing that we work really hard on is to make sure if you walk in the door, you don't get 50 different versions of everything. So we sit together and make sure that the treatment you're offered at one place is the same that you're offered. So don't feel like you have to, if you talk to one of us, you talk to all of us. So radiation oncology and prostate cancer, let's talk about that. Three main pillars: surgery, many of you have had surgery, medical therapy, and I'm just lumping that all together, the hormone treatments, the chemotherapies, and now some of the newer drugs that are tagged with radiation, so it crosses this line a bit. But those, when you get a medication or infusion, it's kind of in this category. When you have someone operating on you, it's obvious it's a surgeon. If you see me with a scalpel run, I shouldn't have a scalpel in my hand. But so surgeons, they train and they do prostatectomies. I do not. Radiation therapy is then the third pillar, and it has a big range of different techniques and possibilities. Because when you think of surgery, it's the prostatectomy, and then in the modern world, it's the robotic assisted prostatectomy. In the medical therapy realm, Lupron, you have those different they're anti-hormone. They lower your testosterone drugs. But there's a whole burgeoning world of chemotherapy in prostate cancer, and the FDA has approved a lot of new drugs in the last decade, which is very exciting because it was sort of early in your venture, there was hardly any drugs. And now there's many drugs, and so the good news is there's many drugs. The painful news, there's many drugs, and so you have to sort of really sit and learn what they are and which ones are good for you or not good for you. But it's exciting that there's been a lot of movement in the drug realm in prostate cancer, which there wasn't for many years. And then in radiation, we have what we call external beam radiation, where you lay on a table and the radiation is aimed at you from the outside. And then there's the internal radiation, which we refer to as brachytherapy, but it's basically when you have things implanted in you and they give off radiation either temporarily or permanently. So those are the two forms of treatment with radiation. It's been around for a long time. The first patient treated with prostate cancer was in 1909, not 2009, but 1909. It's amazing. It's been over 100 and nearly 20 years of treatment. So the important thing about that is we've learned a lot about what to do, and we've learned a lot about what not to do. Over millions and millions of people being treated worldwide. So when you talk to someone today and they talk about a technique, it's been tried and it's been around for a long time. It's now some of the machinery and the computer science to make it safer and more focused, but the use of a beam of energy of radiation for prostate cancer is actually nothing new. And it's been around for a long time. We often use the word adjuvant therapy, and what adjuvant means is from the Latin adjuvare, which means to help. So adjuvant therapy means after something else. So if you've had prostate surgery, we often come in and give radiation either at the time of a PSA rising or if there's a positive margin. That's to help the surgeon have a more successful case, surgery plus adjuvant therapy. Adjuvant therapy might also be a drug therapy. So you're going to hear definitive treatment, which is, if you're using radiation alone, we call it definitive radiotherapy. If we use it in combination with something else, it's called adjuvant. So the two main approaches are external beam, or EBRT, which is just external beam radiation therapy. You lay on a couch, computers are assisting us in aiming the beam at the prostate or the seminal vesicles or the lymph nodes, but it's a computer assisted technique. And you can think of that, the surgeons are using robots and computers and things. We're also doing that as well. We're taking advantage of technology to do a better treatment that's been around for a long time. There are two main types of radiation beams. A photon beam, which is an X-ray. It's an energy beam that comes through the air. It's a wave of energy. Or it could be protons. Protons are particles. They're both radiation. They're just different types of radiation. You can either have a beam of energy, which is a wave, or you can have a particle. And there's different indications, there's different usage, but those are the main differences. It's very confusing because it differs with one letter. Photon, proton, so there's an H and an R, but often we call this X-ray therapy and particle therapy just to get away from that kind of confusion with the names. So external radiation, when it's a X-ray therapy, the machines are not that big. They can fit into a large room. But when you lay on a table and this machine is going around you, that's all there is. There's nothing behind the walls. There's nothing extra. It's a machine in a room. Proton therapy is very different. And you can see a guy standing here. You won't see anything like this because what the patient sees is just the couch and the room. And then behind the wall is a 3-story building with this huge apparatus behind it. And so it's very different. So to make particles and deliver particle therapy is a more complicated technique than this. This is complicated enough, but then there's the added hardware and this big structure. That's why it's at the California Proton Center. It's a building housing this kind of big equipment, but you will not see it when you walk in. It will look like just a regular room, but this is behind the scenes of what you see. So when we give external beam radiation, you can either give it in small doses over a long period of time. Some of you who were treated 10, 15, 20 years ago came for like 7, 8 weeks, almost 9 weeks of treatment. We call that fractionation. Fractionation is just how many doses do you get? How much is the total amount divided up? In the old days, you would divide it up into little bits and give it over long, long periods of time. It's now being what we call hypofractionation, meaning you're squishing it into a shorter period. But the important thing to note, less number of days doesn't mean less dose. It's squashed into, so you get more per day. It adds up to the same amount, but some people go, I don't want the less treatment because I'm getting less treatment. No, you're just getting less days, you're getting more per day. You can think of it simplistically like a bottle of pills, and you're taking lots of little pills, and instead you take fewer big pills. It's kind of the same idea. I think a pharmacist would scream if they heard that analogy, but it's basically the idea behind it. I know they would scream with that analogy. So you can either deliver it over 5 or 6, and this is the standard practice today. Many of you could have 28 treatments, where we used to do 44 and really high numbers of treatments. We're now exploring in the field even going shorter, going like for 5 days or less. That is sort of really getting it squashed, giving a big dose per day. So convenience-wise, there's no question, right? It's like, oh, I don't want to come for 28 times, 33 times, 44 times. I want to come for 5 times, but we have to weigh the benefits and risk of giving a big dose per day. Because remember, right next to the right next to the prostate is the bladder and rectum, and we have to be very careful when we are treating around the bladder and the rectum. Then there's the internal type of radiation. It can either be the seed type, where we put in seeds radioactively that give off treatment for a number of weeks. By 60, 70, 80 days, they're pretty much given off everything. Or we can do it temporarily. And the permanent one is called low dose rate, or LDR, seed implant. The internal one is called HDR because it stands for high dose rate. The important thing, it isn't like low dose with the seeds and high dose with the needles. It's the rate, how quickly you get something. You can get it for over a few minutes, or you can make it stretch out over 60, 70 days. But you don't have to visit that many times. The seeds are inside you for a long period of time. So let's talk about the general process. You come and see a radiation doctor, and you do what normally happens. You talk to them and talk about the pros and cons of what they're doing. And it's often, if you're an early patient, it could be about treatment at all. You might be an active surveillance patient, and you just are talking about, should I get treatment? Should I not? How often should I be followed? And your PSA. And what things would change to flip me over into needing treatment? You're going to talk about this a little bit? No, you're not. So a little bit. So this idea of active surveillance is a big deal in prostate cancer, because in the old days, when I first went in the field, everyone was treated. If you got a biopsy that said prostate cancer, you were immediately operated upon or treated with radiation. That is not true in 2023. If you have a low 3+3 Gleason, PSA that's less than 10, that's a patient that should be talked about whether they should be observed and watched and treated only if things happen. That's a big deal. That changed a lot about the treatment of prostate cancer. Not everyone's eligible for that. If you have certain features on your pathology or PSA, you might not be eligible for that. But because I have patients that come in and they have a PSA of 50 and they have a Gleason at 5+5, and they say, oh, my friend was watched. You're like, no, you can't be, they can be watched, but you can't be watched because you have more aggressive disease. So not everyone can be watched, but the exciting thing is, unlike other cancers, there's a group of people that can be followed without treatment. That is rare. You don't, if we had a patient with lung cancer come in and we said, let's do active surveillance, you would have to have your license removed. Because that's, or breast cancer, let's just watch it. No, there's nothing like that. But prostate cancer, there's a big group of people that can be observed and not be treated unless things worsen. Then you come in for what's called a mapping session. The word we use is simulation. It's like from the military, the flight simulator where the pilot's trained. Basically, it's kind of the same thing. It's not a treatment. It's a measuring, mapping, preparatory experience. But we use the word simulation for that. It's kind of confusing. Then you drop out of the picture, and we do our homework. We use all the imaging, we use everything to prepare your plan. Your plan is the work of the computer, of us as doctors saying what to do, the physicists, everyone's working, and it's going to deliver a plan to you, a plan of radiation, customized to you. The same, if it was the same thing, like, pharmacy community is going to get really mad at me, but if you're taking a penicillin pill for a certain thing, you get the same dose, you get the same pill as the next person. That's not true in radiation. It's also not true in surgery. The surgeries are not going to be identical. You're going to be tailored to your anatomy and everything, so you have to be customized to everything about you. But then the planning involves all these things, and a word you'll hear a lot is IMRT, and that's intensity modulated radiation. And basically that's a way to use the computers to focus the radiation on where we want to treat and to minimize the dose to where we don't want to treat. Today, this is the standard of care for photons. In the old days, we used to say, oh, we could use IMRT, or no one does not. I mean, if you get photon treatment today, it should be IMRT. So in some ways, IMRT is just not modern focused treatment. But it's funny, a patient not too long ago, I didn't say the word IMRT, and they went to a different radiation doctor because they thought, oh my God, he's not going to do IMRT. And I'm like, I don't know what else. If I told my team to use non-IMRT, they would think I'm an idiot. But nonetheless, I didn't use the word. Then the delivery of treatment is where you come back and forth every day. And that's an important thing because we're trying to make every day exactly the same. It's like, oh my God, with the pharmacy community, your pills that you pick up in a bottle are identical. We want to make the treatments identical. Today, we're exploring whether we should adapt the daily treatment to make it not identical. But in general, in the United States in 2023, your daily treatment is very identical. That's why they want to position you. They want to take images. They want to look at how much urine is in the bladder because they're trying to reproduce everything consistently from day to day. So as I talked about external beam with photons or protons, conventional, over a long period, very uncommon today. More hypofractionated SBRT, stereotactic body radiotherapy, fancy word for 5 treatments or less, highly focused. Then the brachytherapy is another version, either with the seeds or with the needles. You can combine the two, and that's very common. We use something to treat the pelvis with x-rays. We could use seeds to boost, give more radiation. So there are ways to give it together. And we commonly combine all this radiation treatments with some type of drug, either Lupron, Casodex. There's drugs that we're going to be using in conjunction to make the radiation actually work better. And then I said we can use radiation from the outside after surgery. We don't do brachytherapy after surgery because there's nothing to stick the needles or seeds into because the prostate is taken out. But we don't use hypofractionated treatment or 5 days of treatment after surgery. That would be too toxic after you've been operated upon. I think in Europe, they're exploring how to shorten it a little bit, but it's still standard to give about 33 to 37 treatments after surgery. We use a terrible lingo. We call it salvage RT, because when the PSA is going up, we say, let's give salvage radiotherapy. It's like, what a terrible term. What the word meant was, now we're going to go back in and try to knock the PSA down and cure the patient when their PSA was rising. But it's a horrible word, but you'll probably see it on the internet and other things. The doctors will use that word. Hopefully, I've never said that to a patient, salvage radiation, but it might come up. Then we have Dr. Seibert here to talk about imaging, but imaging plays a huge role in the radiation approach to prostate cancer. It could be in the diagnosis. You know, PSMA can help find where tumors are. It's used in the treatment. A lot of our machines today image you while you're on the table. So a patient will lay on a table, you will hear kind of a hum, and then there'll be a few seconds, and then the table will move. And what's happening is you're being imaged. The therapists are working with the computers to see where they're aligning you. And if they need to move, make some adjustments, the table's automatically moving. And then the treatment's delivered. So imaging has a huge role in it. In the old days, we used to just put marks on the skin and base the whole treatment on where the marks on the skin were. And you don't have to go to medical school to figure out marks on skin are not an ideal way to aim things, but it gets us in the, we still use the marks to get us into the general range, but we use the internal imaging to finally aim where we want to treat. So let's start with Brent and Dr. Rose. He's now got promoted. He's now an associate professor. He's the section chief now that John has departed, opened up an opportunity for him. He took over as director of the prostate cancer section. He has a joint appointment in the Department of Urology, so when you talk to him, you might see on his business card, it will say urology. He's not a urologist, he's just a member of their department as well. He trained at a little-known school on the East Coast, Harvard University, and he is a recipient of many, many grants, especially through the Department of Defense. The Department of Defense is a wonderful supporter of prostate cancer research, and they fund a lot in the field, and he has several large grants from the Department of Defense focused on how to look at prostate cancer, how to improve how we're treating people. But I think the VA and the Department of Defense really leads the story about this disease, which is really nice. That's a great role for the Department of Defense. He's published extensively in high-impact journals and has studied a lot about the outcomes of prostate cancer. His clinics, as I said, are here and at the Proton, here in La Jolla and at the Proton Center. Okay, so why don't we transition to Brent?
All right, well, hello everyone. It's great to see everyone in person again. It's really exciting to be back in person. You know, we've been doing these talks for a long time, and it was so nice, you know, at first when we get to meet everyone, face-to-face conversations, and then when we went into Zoom, you know, for better or worse, it was still nice to be able to continue the meetings and continue speaking, but you really sort of lost that feeling of connection with the people and really talking about individual cases a little bit more. So it's really nice to be back in person. So thank you so much for having us. You know, again, I'm Brent Rose. I'm one of the radiation oncologists, and I really love this meeting, and I love this group because it's positioned in the right way. It's really designed to help educate you so that you can be your own case manager, and that's important in prostate cancer. In other different types of cancers, you'll go into the doctor's office, and there's a very straightforward thing that you have to do. Everyone gets the same treatment. That's not how prostate cancer world is. You know, everyone who has met doctors so far is you'll often get one doctor to say, oh, you have to have this treatment. And that's usually not true. There's lots of different treatments you could have. you'll also meet other doctors say, okay, well, here's the 10 different treatments you could have, you pick, good luck, which is, useful, but also challenging, right? So how do you make that decision? And realistically, when you get a diagnosis of prostate cancer, when a loved one has a diagnosis of prostate cancer, you sort of have to get this PhD in prostate cancer world to understand what is the right option for you, what is the right thing for your specific case. Because there's not a one-size-fit-all approach to anybody. There are options that maximize quality of life, there are options that maximize intensity of treatment, there are surgical approaches, radiation approaches, so you really need to learn a lot of information before you can really make the right decision for yourself. And so my topic is actually a little bit of basics. If you're going to get your PhD, you got to start at the beginning. You got to get the 101 in there, really understand what we're talking about. When the doctors are saying Gleason scores, PSAs, what does that even really mean? And so we just want to start in the beginning, and some of the other doctors will go to a little more advanced talks about specifics about radiation oncology. Just want to make sure everyone's on the same page. And so part of this is from being at meetings before and answering questions of the guys who come up to us, and there's this big spectrum. Some people here already have their PhD in prostate cancer world, and some people here will have just been diagnosed, kind of swimming in jargon that they don't really understand. And so we hear a lot of the similar questions, and we'll try to just talk about some of those questions with you. So the prostate sits right here in your body, and that's next to three very important structures that we really care a lot about as guys, right? So right on top of the prostate is your bladder. That holds the urine. When you have to pee, it fills up. And then when you actually go to the bathroom, it's a muscle. It squeezes, pushes the urine out. But it pushes it through a tube called the urethra that's right in the middle of the prostate. It goes right through the prostate, then out to the penis. Also sits right in front of the rectum. That's, of course, when you have stool in your rectum, it fills up. And then when you have a bowel movement, the rectum also squeezes, pushes that stool out. And then, of course, there's the penis, which does a lot of important things for voiding and for erections and things like that. And you can kind of see here that there's a collection of nerves and blood vessels that kind of run right beside the prostate, go down to the penis, very involved in erections. So those are three very important things. And a lot of what we talk about for cancer treatments are how much is this going to affect the prostate cancer, but what about the other organs nearby? What affects us? What side effects are we going to have for these treatments? So it's important to get a sense of what the anatomy looks like there. So a lot of people will come in and say, okay, well, I know my cancer is getting worse because I'm having a harder time peeing. I'm getting up more times at night to pee. My prostate cancer must be a cause of obstruction. That's it's very rarely true. Because if you can imagine that your urethra is right here, the prostate cancers usually grow up actually in the back of the prostate, away from the urethra. When those urinary feelings that you're having, if you still have your prostate, is usually just normal prostate growth. As guys, we have prostates, it gets bigger over time, but it particularly gets bigger in this transition zone, which sits right around the urethra, and it just squeezes the urethra. So most of what you're feeling with your urination, getting up at night to pee, is your normal prostate growing. It has nothing to do with your prostate cancer. There are cases with more advanced prostate cancers where the cancer can grow towards the urethra, but the majority of the time, the urination is totally separate from your cancer. It's important for us to know about it, urologists, radiation oncologists, even medical oncologists, because the treatments can affect urination. We just want to make sure that you're not at home thinking, oh, I got up 5 times last night, cancer's getting really bad. Totally separate issues, okay? Another question comes up, is the cancer causing problems with my erections? Again, usually not. Usually, as guys, we get older, erections just aren't quite as good as they used to be. The older we get, the more that's true. But the prostate cancer on its own doesn't typically grow into that neurovascular bundle enough to affect the erections until it's quite advanced. So mostly that's a separate issue, can certainly be affected by the treatments. It's something we need to think about, we need to talk about. It's a big quality of life portion for a lot of guys. But it's probably unrelated to the cancer itself. And then a question that I know a lot of guys have, I've had for a long time, is what does the prostate actually do? What is it doing? It's just kind of sitting there causing problems waiting to get cancer, right? And making it harder to pee. Well, what the prostate actually does is creating the fluid that comes out when you ejaculate. That and the seminal vesicles. So these are the seminal vesicles and the prostate. They just create the fluid that comes out when you have an ejaculation. And so that carries the sperm into the vagina. There are some enzymes to sort of change the pH in the vagina to allow the sperm to get to the egg. So it's an important reproductive organ, but once you're of a certain age, you don't really need those things to happen anymore. So then it's just kind of sitting there. But because of the geography where it's sitting, it is important that we treat the cancers when we need to, but do it in a way that causes the least amount of side effects on the bladder, the rectum, and for erections. And a term you're going to hear a lot, if you haven't already, is PSA, prostate-specific antigen. What is PSA? Why are we always talking about the PSA? Well, so the PSA is a protein that's made by both the normal prostate and the prostate cancer. So everyone has a PSA. Every guy has a PSA. When someone gets a prostate cancer, that prostate cancer starts to make more PSA. So the higher your PSA gets, the more likely you are to have prostate cancer. But it's not a perfect test by any means, and I'll go into that in a minute. But some of the uses that we have is, one, screening for prostate cancer. How likely are you to have a prostate cancer based on your PSA? When we know you have a prostate cancer and you haven't been treated yet, then the level of the PSA tends to give us a little more information about how much cancer do you have and how aggressive might it be. If you're not going to get treatment, you're going to get active surveillance instead. It's one of our key indicators of, is the cancer growing, or is it just kind of sitting there calmly and we can just continue to ignore it or to monitor it for a while. And then after you've been treated, then it becomes one of the most important ways to know, is the cancer controlled or is it coming back? And so people always say, well, what's a normal PSA? My PSA is normal now. But the problem is there's no real normal level of PSA, and it totally depends on where you are within this cancer spectrum. You'll often hear, well, less than 4 is normal, more than 4 is abnormal, because that's what the labs will sort of report out as an abnormal level or not. That's kind of true in the setting where you don't know that you have prostate cancer and they're doing a routine PSA screening test. The problem is, even that, it's not perfect, because about 15% of guys who have a PSA less than 4 have a prostate cancer in their prostate, and the PSA just didn't get quite high enough to detect it. And then almost 50% of guys who have a PSA all the way up to 10 don't actually have prostate cancer. It's just they have a big normal prostate. And so it's an indicator of whether or not you might have prostate cancer, but it's not perfect by any means. It's sort of the best we have right now. People like Dr. Seibert are working with genetic testing and MRIs and better ways to really find prostate cancers we need to find, and ideally not find these really early low-grade ones, which just kind of get people scared and don't actually have big potential to spread and cause problems. But that's sort of what it is and what it's used for in the upfront setting. A couple problems with the PSA test. So you can imagine, if your prostate is big, again, your normal, non-cancerous prostate, if that's big, as it gets, and in a lot of guys as time goes on, that PSA level just goes up a little bit, and that's okay. Doesn't mean you have necessarily cancer. People can get inflammation of the prostate also. We call that prostatitis, and that makes the PSA go way up. And so sometimes it's almost like a urinary tract infection, but it's actually in the prostate itself. Of course, prostate cancer can cause the PSA to rise. Things like having had sex and having a recent ejaculation, that'll make your PSA rise. If you're still going to screening, you've just had sex or had an orgasm before you get a PSA test, that can make it falsely elevated a little bit. Anytime someone examines your prostate, that will make the PSA go up, and even just bicycle riding or anything that actually causes some pressure on the prostate will make the PSA go up. So those are all important things to think about. If your PSA is fluctuated, you're on surveillance, 6 months ago your PSA was 5, this time you get your PSA and it's 6, but you went on a bike ride, or you had sex, or you had an exam right before your test, and things like that. There's a lot of variation in that PSA number, particularly before you've had cancer treatment. Okay. Once we know you have a prostate cancer because we've done a biopsy, then the PSA really tells us a lot of information. Is it typically, if it's less than 10, or 10 to 20, or over 20, those are kind of the buckets we think of within PSA for risk stratification. When it's less than 10, that's a pretty good risk factor. That tells us either that there's not a lot of prostate cancer, or that cancer is not making a lot of PSA. So that's generally a good sign. That's not the only piece we think about, but it is important. Once it gets 10 to 20, it's telling us, okay, well, it's making a decent amount of PSA. This is something we need to be taking pretty seriously. If it's over 20, that alone will put you into the high-risk category, and that means high risk that it could spread if we don't treat it. So we do want to take those pretty serious, okay? And then I think everyone here will have strong memories of this event when it happened. And so this is the prostate biopsy. Most guys will have had a prostate biopsy at this point, and you can all remember that there is an ultrasound probe that goes into the rectum. There's a needle that comes off the probe, and it samples largely the back of the prostate, looking for prostate cancer. And again, remember I said that most prostate cancers grow right there in the back of the prostate. So that's okay. You're coming from the back. That's a good thing to get to where most of the prostate cancers live. But some of them live right here in the front of the prostate, and those are actually kind of hard to get with a standard biopsy. One, because the needle it's hard to get all the way to the front. Two, they're trying not to put that needle through the urethra, because if they put it through the urethra, then you pee blood for 2 weeks or a month, and it's not that much fun. So there are times when there is a little more prostate cancer than you expect based on the biopsy. Probably about 30% of the time there's actually more cancer there than you'd see on the prostate biopsy. There are cases where we're getting an MRI or something along those lines to really look for other areas of the prostate that might have cancer that are harder to get with a biopsy. So those are questions to talk about with your doctor. And this is what we call the Gleason grading system. And I think that they designed this to be as confusing as possible. So if anyone has heard about your Gleason score, it's kind of like there's 3 + 4 is 7, but that's better than 4 + 3. So it's horribly confusing. Historically, there have been 2 numbers. There's the first number, a second number, and you add those together to get a third number. So that would be 3 different numbers you'd have to remember. But unfortunately, each part of those numbers was important. What that really means is they do the biopsy, and they look under a microscope, and they say, how aggressive does this cancer look? But prostate cancers are funny because there are, not all the cancer looks the same. There are parts of the cancer that look more aggressive, and there are parts of the cancer that don't look quite as aggressive. So they end up actually kind of grading different patterns based on how aggressive each part of the cancer looks. And so the first number will be the majority of the cancer. What does the majority of the cancer look like? And they'll give that a number between 3 to 5. And then they'll look, okay, well, are there small parts of the cancer that look different? And then they'll give that a number between 3 to 5. And then they'll add those up, and it'll be somewhere between 6 to 10. A lot of problems with that, though, right? If you're a guy, you don't know that much about prostate cancer, you're in the office and say, you got a Gleason 6, and you say, oh no, 6 is close to 10, that must be pretty bad. What about 1, 2, 3, 4, and 5? But 6 is actually the earliest prostate cancer you could have. So that's low-grade prostate cancer. That's actually sort of the best that you could have in terms of if you're going to have prostate cancer. The other issue is the sequence matters. So if you have a 3 + 4, that's better than having a 4 + 3. And again, it's just because if you have a 4 + 3, that means you have a lot of that 4 compared to the 3. And if you have a 3 + 4, it's mostly that lower grade stuff with a little bit of the higher grade stuff. So that's actually a little bit better, and studies show much better outcomes with that. So someone decided to try to make the system less confusing by just saying, okay, we're not going to do all 3 numbers. We're just going to do a 1 to 5. Makes sense? So then you have these grade groups, 1, 2, 3, 4, and 5. So a 1 is, again, that lowest grade cancer. A 5 is the highest grade cancer you can have. That's a pretty logical system, but the problem is everyone else is talking in this system. So now you have 2 different systems you have to remember because we haven't fully converted over from one to the other. So it's important when you're talking to your doctor to clarify Gleason score is the 3-number digit. You'll often hear a 6, 7, 8, 9, or 10, and not just the first 2 because they're trying to make it a little bit easier, but that's the Gleason score. Some doctors will be talking in grade groups, and that'll just be 1 to 5. I wouldn't worry too much about that right now because most people are still talking in Gleason scores, but just wanted to give you a sense of if your doctor is talking to you in grade groups, that's what that converts to. Okay. So prostate MRIs. Prostate MRIs are great. Dr. Seibert's going to talk a lot more about them, but they give us a lot of information that is not obvious on other modalities. So this is a prostate MRI. You can see this is the prostate here. This is the rectum right behind it. These are just some muscles in the side of your pelvis. You can see this big dark area here is a prostate cancer. Remember I said that the biopsies usually come from the rectum and put needles forward like this into the prostate? You can miss that prostate cancer pretty easily. And so MRIs are actually quite useful by saying, okay, well, we're suspecting prostate cancer. Where should we try to get those needles to make sure that we're assessing it as well as possible? And in this case, you could see, well, you got to get that needle all the way to the front in order to make sure you biopsy the worst part of your cancer here. So where a prostate MRI fits into anyone's picture is still kind of a moving target. There's a lot of data out there. There's a lot of trials. Should they become always before a biopsy? Should you get a biopsy first to know that you have the cancer and then get an MRI and then maybe do another biopsy to target it? So there's a lot of moving pieces. I think we here would suggest it's probably better to get your MRI before your biopsy for this exact reason, so you don't get a negative biopsy that misses a cancer. But there are other considerations there. So consider getting a prostate MRI before you're going to get a biopsy. If someone's going to tell you, okay, we're going to do a biopsy, ask them, should we get a prostate MRI first so that we can target it? That's an important consideration. If you're on active surveillance and your PSA is rising and it doesn't seem to fit, you got a biopsy with a little bit of Gleason 6, but your PSA is now getting over 10, definitely want to make sure that you have an MRI just to rule out the fact that they could be missing something that's just harder to biopsy. When you have a known prostate cancer, you want to know how aggressive it is. Sometimes an MRI can be useful to see, is it growing outside of the prostate? Is it growing into neurovascular bundles and things like that, which can affect surgery planning? And then an important topic that Dr. Seibert's going to mention is for focal targeted treatments. And when we hear focal treatments, there's sort of two categories. There's the category where you're only treating the focus spot you see on the MRI. That's not typically what we do with radiation because prostate cancers are often multifocal, meaning if you just target that with a focal treatment, you end up with a recurrence right here because there's a little prostate cancer right here also. So we don't usually advocate for only treating one small spot of the prostate based on an MRI. We'll probably get there at some point when the MRI technology or the imaging technology is better at identifying where exactly the cancers are. But instead what we're doing is treating the whole prostate, but then giving extra radiation to the spot where we know that the worst cancer is. And Dr. Seibert will talk more about that. The other question you always have to know is, has the cancer spread? And how would we know if the cancer had spread? So prostate cancers usually, if they spread, they go to bones or lymph nodes. Those are the two most common ways where they could go. So historically, we'd get a CT scan of the pelvis and abdomen looking for those lymph nodes, and you'd get a bone scan looking for a cancer that spread to the bone. But anyone who's had a bone scan probably knows that it's going to show arthritis, that one time you fell while you were playing basketball outside. And so there's a lot of what we call noise on bone scans. It's hard to tell if what you're seeing is a cancer. It's hard to tell if it's an arthritis or something like that where your bones are just have a little bit of inflammation. And it also misses a lot of cancers because it's not as sensitive as other techniques. So those standard modalities are getting replaced by PSMA PET scans quite a bit. So instead of a CT scan and a bone scan, you're often getting a prostate MRI and a PSMA PET scan instead because they give more information than the older techniques. They are a little bit more expensive, so insurance companies will try to fight it sometimes, and some doctors order them, some don't, and so you want to make sure that, in your case, you're getting the appropriate imaging test that you might want. So nowadays, people with high-risk prostate cancer or higher, or cancer that has come back after a prostatectomy, those are cases where a PSMA PET scan can be helpful to look for other spots of cancer spread. There's the caveat there that PSMA PET scans are pretty new. We're finding a lot of things that we're not entirely sure how to interpret on a PSMA PET scan. And so if you get one of those, you'll often come back and say, well, I see something in one of the ribs, and I don't know if that's from a fall or what we can do. So you end up having to do some more biopsies and things like that. But it is a very, very useful test. And then the question we always get is, what stage am I? And the hard part for prostate cancer providers like us is we don't usually use the standard staging system that everyone else has heard about. The stage 1, 2, 3, 4. It doesn't work quite as well for prostate cancer. And the reason is those staging systems are designed to say, where is the prostate cancer? And that's important, or where is the cancer? So that's important, but it doesn't incorporate what the Gleason score of the prostate cancer is, what the PSA is, and things like that. And so we, instead of using standard staging systems, we actually use risk groupings. And so the most common situation is you end up with localized prostate cancer, meaning the cancer is confined just to your prostate. And then within that group, we break that down into low risk, meaning you have a Gleason 6 or less, a PSA 10 or less, and cancer not growing outside of the prostate. In these cases, we usually recommend active surveillance. Most of the cancers don't have a high potential to spread anywhere else, and any treatment we can do is going to potentially cause some side effects. So most low-risk prostate cancers, we just want to observe, frequently check your PSA, maybe repeat a biopsy. Then there's the intermediate risk grouping, which we have broken down into favorable intermediate and unfavorable intermediate. And this is based on a few different criteria. They're probably a little nuanced to go into right now, but in the favorable group, we're trying to either do active surveillance. It has a little bit of a potential to spread, but in the right person, active surveillance makes sense. But ideally, if we're going to treat it, we only treat it with one modality, meaning just radiation, just surgery, not multimodality therapy with lots of different treatment types. Once you get into the unfavorable intermediate risk, if you're getting radiation, you're probably doing that with a little bit of hormone therapy, or at least discussing hormone therapy. If you're going to have surgery, the chance that the PSA rises after surgery and you need the radiation afterwards starts to rise. So in this group, we're usually starting to talk about multimodality therapies. Regional involved lymph nodes. Interestingly enough, about 10 years ago, if the cancer spread to the lymph node, we said, well, the cancer is metastatic, there's nothing we can really do about that. That paradigm, regional involved nodes, so those are pelvic lymph nodes. Nowadays, with better imaging, we're finding a lot more pelvic lymph nodes than we were when we were there. We're treating these aggressively for cure and having really good outcomes. So the paradigm, this is actually called a stage 4 in the standard staging system. But there are a lot of cases where we can eradicate this disease and it doesn't come back after treatment. So we don't think that it should be called a stage 4. Often people think of stage 4 being incurable types of cancers. And of course, there are the cases where the cancer has already spread to bones or lymph nodes outside of the pelvis. We do call those metastatic. And the paradigm there has shifted dramatically as well to we're often still treating the prostate and the spread of disease with focal radiation. And this is a type of cancer that we can fight for a very, very long time. You know, it used to be old hormone therapy, just Lupron was all you really had. But in this case, radiation options, newer hormonal therapies, is really prolonged survival and outcomes in this case. And we can often just treat this like a chronic disease that we keep fighting for, decades. As you mentioned, there are people here, 20 years of having cancer and still living a great life, good high quality of life. And so this is not the situation where it used to be. Another question, should I get a genetic test? And if so, which one? I think we're holding questions till the end, or? Yeah, okay. Sorry, we'll get to that. Should I have a genetic test, and if so, which one? So this is an interesting question, and the guidelines actually are now starting to encourage genetic testing. But it's really important for you to know that there are two different types of genetic tests that you could do. One is looking at your genes. What genes did you get from your parents that you pass on to your children? We call those germline genetic tests, but that essentially is referring to your genes. And what we're looking for is, do you have a gene that predisposed you to get that prostate cancer in the first place? It's not that common that people have those genes, but if you do have one, it's good to know about because you can tell your children about it. You can make sure that they're being counseled appropriately. So that's a germline test. That's now recommended for high risk or metastatic prostate cancer. Still not low and intermediate risk prostate cancer, but high risk for metastatic prostate cancer, or those who have a strong family history of prostate cancer. The other class of tests is testing the genes of the tumor itself. So in any type of cancer, prostate cancer and others, the DNA gets mutated. And so the DNA is kind of like a blueprint, the instructions for the cell. It tells it what it's supposed to be doing. But there are mutations in that DNA where the code starts to tell the cell to do something else that it's not normally supposed to do. And usually in cancer cases, it's telling it to grow, to spread, to move to other different areas of the body. And we don't want that to happen, but that's what's happening in some tumors. So in certain cases, we're actually sending the tumor's genes itself to look for which mutations does it seem like are happening in that cancer cell and what might be making it happen. And that could affect how likely the cancer is to be cured. It could affect which type of treatments you might want to do. And so there's a lot of different uses for tumor testing. That's a several-hour topic on its own, so we're just going to leave it there. But just want to know that you think of germline or tumor testing, and is that right for you? If you have high risk or higher, then you're thinking of some of these tests. If you're lower risk and you're thinking about not treating it, sometimes these tumor testings can be helpful. But it's something to ask your doctor about. So then just wrapping up with some common questions that we hear a lot. The first is, my doctor says I need a treatment right now, but I don't really feel like I understand the situation. How urgent is this? Do I really have to get my treatment next week? In prostate cancer world, it's usually not that urgent that you can't take your time to make sure you understand your cancer, that you've talked to other doctors, other people who have a similar situation to you, and make sure that you're making the right decision for yourself. So it's important. You don't want to wait years, but waiting a couple weeks to get a second opinion, to talk to a few more doctors, really a valuable part of your medical care. So make sure you take the time to understand your situation and what's the right option for you, based both on your cancer and your goals with your body, where you want to do. Are there other doctors I should see? Probably. You probably want to have a urologist, you probably want to have a radiation oncologist, and you might want to have a medical oncologist as a third opinion. So make sure that you're hearing the information from the right doctors and that you're processing the information. The other thing is, if you talk to a doctor and you didn't understand anything he said, or you didn't like him, or whatever, that's okay. Get a new doctor. You have totally a right to get a second opinion if what you're hearing doesn't click. That's okay. It happens all the time. Sometimes I talk to patients and they don't, we don't click and they get a second opinion. I'm not offended. That's okay. That's your right. You have to make sure you understand your cancer. So definitely get a second opinion if what you're hearing doesn't sit well with you, you don't really understand what they're saying, you're not communicating, just get a second opinion. That's okay. Why do we have to treat the whole prostate? I mentioned that. Prostate cancers are multifocal, so you usually do have to treat the whole prostate or it comes back in a different area of the prostate. It's not always true, not 100% true. As imaging technology gets better, we'll probably move toward more focal treatments, but for now we still do the whole prostate, potentially plus a focal treatment. This is one of the questions you should ask every doctor you see. How is this going to affect my urination, my sexual function, my bowel movements? Because every treatment is a little bit different. Surgery is going to have one set of side effects. Radiation is going to have a totally different set of side effects. Some people are better suited to surgery for various reasons, and some people are better suited to radiation for certain reasons. And so it's important that you're talking about all of those different domains. And I put here identity because, this is in a very important area of a person's body, and there will be changes. Whether it's surgery, radiation, hormone therapy, things are going to change. If you lose the erections, if the hormonal therapy produces your testosterone, you might feel a little different. And so it's important to realize that this is a part of you as a person. You're a whole person. You're not just a single organ that has a cancer in it. How is this going to affect every part of you? And the only way to really get to that is to talk to other people. Talk to people that have been through it. Make sure you have doctors that you're comfortable explaining what your real goals are, what your priorities are, and then really just take the time to make sure that what you're doing is right for you. And then it's a scary time. New cancer diagnosis, it's a scary time. Hormone therapies, surgeries, radiation, there can be an element of depression and anxiety that goes along with all these diagnoses. That's normal. That's not something that you should sort of hide or feel like you're not a man if you feel depressed or anxious or scared. It's a normal part of this journey. Make sure that you have people that you can talk to, whether that's here in this group. I know everyone here is very supportive, loves to talk about the challenges that they're facing, but sometimes that's a medical professional, sometimes a psychiatrist or psychologist. That's okay. That's not a problem. That's not something that you are abnormal or you can't sort of wrap your head around it because there's something wrong with you. It's a normal part of it. Make sure that you are addressing those needs as well. Okay, so that's all I got. I know it's a lot of time. We'll pass it over, and we'll take questions at the end. So thank you so much, everybody.
Thank you all for your attention and for having me here. I'm going to focus today on targeted radiation therapy for prostate cancer. This is something that's fairly new. And I'll give you a little bit of background and everything. And as Dr. Mundt mentioned, my background is coming from this engineering and imaging field, and I realized while I was preparing this that it was 2 years ago this month that I started as an engineering student in MRI research. So I don't feel like I should be old enough to do 20 years of imaging research, but here we are. A nice way to celebrate. So radiation therapy for prostate cancer, or radiotherapy, that's the same thing. What is the target? Historically, for a long time, it has been you treat the whole prostate. As Dr. Rose mentioned, prostate cancer is often multifocal, meaning there's multiple tumors. So if a guy has a tumor, there's about an 85% chance that they have some other cancer somewhere else in their prostate. So we've always taken the approach that you need to be careful and treat the whole gland, either with radiation to the whole gland or removing the whole gland with radical prostatectomy. There are some now efforts to do focal therapy where you only treat the tumor. Those are experimental. You should be aware that those are experimental, and also that they're done in men who often are borderline about whether they need treatment, and then they have to be followed very closely because they often will have a recurrence because that is an experimental approach. But anyway, in radiation, we treat the whole prostate. So we circle it, and then we tell the computer this is where we want to treat, and that's what we've always done. But part of the problem is we couldn't see the tumor anyway, because look at, this is a CT scan, this is what we had, and you can't see, there's no, where's the tumor in there? It is there, but I can't see it, you can't see it. But now we have MRI, and multiparametric prostate MRI has changed diagnosis of prostate cancer. And Dr. Rose mentioned that we also recommend generally that men get an MRI before a prostate biopsy. I will tell you, I would never consent to a biopsy myself without an MRI first, unless I had a pacemaker. That would be the only reason not to get an MRI first. And that's not just me saying that, that's guidelines from the American Urological Association, that's guidelines from the European Association of Urologists, and it's also the guidelines in the UK. So that is really first world standard at this point. And the reason is because if you have a normal MRI, you probably don't need a biopsy. And if you have an abnormal MRI, you want to make sure they put the needle in the abnormal spot, not just kind of blindly poking around. So now we can find the tumor, and that's where it is. Now, those images aren't that easy to see. This is an easy one, actually, but you probably didn't see that spot, and I'll show you a little bit more about what I mean. But first, why do I care? Why do I care about finding it for treatment? Not for diagnosis, but for treatment. There was this phase 3 randomized trial. So this is the highest level of evidence for medicine, is a phase 3 randomized trial. It was conducted in the Netherlands. It was published in January of 2020, or was it 2020? I think it was. No, I think that's right. I think it's 3 years. I had said 2 years, but I think it's 3 years now since this was published. So this was comparing treating, it was 571 men. They all had intermediate or high-risk prostate cancer, so all cancers that need to be treated, not the kind we watch. And they were randomized to either treating the whole gland over 35 fractions, so 7 weeks of treatment, or treat the whole gland, but give an extra dose every day to the tumor you can see on MRI. That was the question, and we'll see. Does doing that hurt people? Does it help them? We don't know, so we'll do a randomized trial and we'll find out. And just for reference, that's about a 42% increase biologically, because you have to account for how much you're giving per day. So it's up to about 42% increase in dose, pretty substantial jump. And here's what happened. The men on the red line here, so this is 100% of men when we started have not had a recurrence. DFS means disease-free survival. So you go down here if you die or your cancer comes back, one or the other. So you can see that the men on standard treatment, they did pretty well, but by the time you get to 7 years out, a fair number of them have either passed away or their cancer has come back. If you look at the ones in red, the focal boost group, it's a better curve. You'd rather be up here than down here. Yeah? So this is a big win for oncology when we see a change in whether the cancer has come back. And you see that if you do an overall analysis and estimate, they're about half as likely to have a recurrence. So what about the harms? Whenever we escalate treatment in cancer, we see some side effects. It comes at a cost. You always have to pay for that cost. But this trial was done in a special way. They said, we're going to go up on your radiation dose to that spot we see on MRI, but we'll only go as high as we can without affecting your normal organs. So some guys had their tumor really close to, say, the rectum, and then you can't quite go as high. Or maybe it was really close to the bladder and you couldn't quite go as high. But some, it was in a spot where they were able technologically to treat that cancer to the full 42% increase. So keep that in mind. Even though the one arm did better than the other, some of the ones in the good arm didn't even get that benefit because they just weren't eligible. And even still, we see a big effect. So what about toxicity? We look at toxicity. GU means genitourinary, so basically urination, and we look at GI. No difference statistically in toxicity for GU. No difference in toxicity for GI. Right? I cannot emphasize how big of a deal this is. I can't think of another example where we've escalated treatment to the point where we got a benefit for patients in cancer, and we didn't see an increase in toxicity. So are we only preventing the PSA from coming back up, or is there something else? Well, they did a follow-up study where they looked to see what happened to these patients that were participating, This was published in the European Urology. That's the one from 2021, so the following year. And actually, local failure, meaning cancer came back in the prostate, was reduced by 2/3 by this approach of boosting. And recurrence in the lymph nodes or farther away in the bones, for example, which is generally an incurable condition, though sometimes Dr. Rose says we have success in some cases now, was reduced by almost 50%, right? So humongous benefit. Fewer metastases, less recurrences, more men cured, and no increase in toxicity. This is a home run, right? Every patient should get it. So are they? We did a survey, in December 2022. So just last month, we did a survey, and this, I said 2 years, I should have said 3. 3 years after the FLAME trial results were published. Are patients getting a focal radiation boost? 205 radiation oncologists responded from around the world. Most of them were from North America or UK. And then I asked, do they offer a focal boost? So the generalists, more than half of them have never done it, not once. Partially subspecialized, more than half don't do it. They do not offer this routinely to their patients. And the completely subspecialized, meaning people who only focus on GU cancers. And in radiation, that's prostate, bladder, kidney. Almost all of our work in radiation for GU is prostate. So pretty much this means these are people who spend all of their time working on prostate cancer. Still, only 2/3 of them offer this for some of their patients. Not all their patients, some of their patients are getting it. So 3 years after a blockbuster result, most patients aren't getting it. And I would say, even in this generalist group, that's probably an overestimation because there weren't very many respondents from that. They're less likely to respond to a prostate cancer survey in the first place. And I suspect that we got the ones who were more technologically oriented and more engaged in new research. So that's the situation. Most patients are not getting it. So what's the catch and why aren't they getting it? There are a few reasons, but I'll focus on one of the big ones today, which is that you can't aim at what you can't see. And radiation oncologists need to learn how to see these tumors on MRI, right? That is not a trivial thing. It sounds easy. It's not easy, actually. Radiologists, whose whole job is to look at images and have an entire residency dedicated to finding things on imaging, they actually can't agree on prostate MRI a lot of the times themselves. Here's 26 institutions. Each of those dots is an institution. Most of these are big name places in the United States. 26 different institutions. And the question is, if the radiologist called an MRI abnormal, said, I think there might be cancer in this, how often was there cancer when you did the biopsy? All right, about 35% of the time. But depending on where you were, it was either close to 75% of the time or 20% of the time. And the red lines are at each institution, how much consistency was there among the radiologists at that institution? Not much. So where you go for your MRI, what's the quality of it? How good was the radiologist who read it? How good was the person who did the biopsy afterwards? Has a huge impact on the result, which is frankly alarming and is a lot of what I'm working on the research side for diagnostic MRI. But for radiation, we also care. So what are we going to do about it? We're going to make MRI better. And we work here, the Center for Precision Radiation Medicine, also the Center for Translational Imaging and Precision Medicine at UC San Diego. We take specimens of prostates, and we learn about what cancer looks like when you stain them and look under a microscope, and we figure out how to make the MRI show us where the cancer is. And this is an example. This is a patient's prostate. This patient had surgery, obviously, so we have their whole prostate out. The pathologist looked under the microscope and found the cancer. This is their MRI. Maybe you can see that there's kind of cancer there on their regular MRI. Maybe you can't. This is now, we've transformed this to make it line up really nicely over the MRI, tell us where the cancer is, and we compare it to our new kind of MRI where we say it should light up where the cancer is, and here's your tumor. Tumor lit up. Yeah, so now that's great. How does it work for us? Better than my pointer at the moment. Whoops, we're too far ahead. I wanted to show you something else. Okay, briefly, the physics of how this works here. MRI, to find cancer, you're looking at water molecules and you're seeing how they move. All right, conventional MRI, what you're trying to find is the water molecules that are in cancer, because you're trying to find cancer signal, right? Regular MRI assumes that water molecules all are just kind of free-floating, like in a glass of water. That's not true. Bodies actually are complicated. They have little tissues and cells and proteins and things there. So in reality, we find that you have water inside cells. That's what we want to find. You have water that's moving outside of cells and trying to get around the cells, and they're a little slower, but not like these ones. You have water that actually is freely diffusing. For example, in your urine that's just sitting in the bladder, that actually can move around pretty well. And then you have water that's actually flowing along in blood vessels. And we have now made an advanced MRI technique that focuses in on this. Tell me where there's cancer. So here's where we test it. This is conventional MRI. This is the structural T2 weighted MRI. This is the diffusion one. They're blurry. Dark spots are cancer. So if you look at this, maybe you can see where the cancer is. There's one, this is a patient, this is a patient. See if you can see where you think the cancer is on those ones. This is the advanced MRI. And those are the spots that are abnormal that you maybe could have seen here and maybe not. So with Dr. Louie, who's an excellent resident at UC San Diego working with me in my lab, we did a study where we asked how well does the advanced new MRI, RSI we call it, restriction spectrum imaging, does it help radiation oncologists find the tumor so that they can target it? So here's an example patient and a few example participants from our group. We had 44 radiation oncologists from around the world participate. And here's some representative examples. So blue is the expert radiologist target. We had 2 expert radiologists tell us where is the actual cancer. And then we give the images to the participants, the radiation oncologists, and we tell them, the radiologist said, we don't show them the picture of where they said, but we said the radiologist said that there is a 1.1 centimeter tumor or lesion, looks like a tumor, in the, I remember I can't see this very well over there, but we tell them something like, it's in the right posterior peripheral zone at the mid-gland of the prostate, and it's 1.1 centimeters. It's pretty specific. And that's what you would get on a radiology imaging report. So in real life, I get a report that the radiologist said this is what it looks like, and then I can go look at the pictures myself, and then see if I can find the spot that they told me they saw, right? So that's what we asked them to do. Here's what they drew, some of them, right, in red, are drawing something that has very minimal overlap with the actual blue thing that they were supposed to be getting. Yellow, they completely missed. They weren't even in the right spot at all. So if they were targeting this, they'd be targeting normal tissue and missing the tumor. It's obviously not ideal. And pink means that it's overlapping with the expert. Now I'm showing you some ones where they didn't do so well. But when we gave these same people RSI, a month later or a month before, all mixed up within a bunch of cases so they didn't know they were seeing the same one they had seen before, they all got it. Same people, no problem, right? All of them are right there on the correct spot. So that was encouraging, right? Here's another example where we have some where they've missed, or here's one it looks like they got it, but if you look in the other plane, they made it way too big, so they're going to be potentially damaging stuff down here for no reason. And then when you give them the advanced RSI, they're right on. Another example, again, misses or way too big, now everybody's hitting the right spot. What we found was that of each participant did 20 cases, all right, one way or the other, so they did 40 cases, but 20 and 20. 20%, 19% of the time of all attempts, 19 were complete misses. It's not even like they partially got, they didn't touch at all the actual tumor. Once they had RSI, without any additional training, that number dropped to 2%. Participants, so I saw that and I thought, you know what, it's going to be all the ones who were least, good. The worst radiation oncologists were ones that missed all of these things. And I was shocked when I saw this number. Actually, 93% had at least one complete miss. 93% had one complete miss. Without any training, just giving them better imaging, we dropped that to 30%. And the average number, the median number of misses, complete misses, per participant was 3. Out of 20 to 22, they missed 3. And with RSI, that drops to 0. So we're excited about this. This is about to get submitted for publication. We did lots of tests on just how accurate were they, aside from complete misses, how close were they and everything. On every metric, the accuracy went up by at least 50%. So the goal is to bring this technology then to the clinic and then have all radiation oncologists get better so that all patients get the benefit of this wonderful thing that we can target the tumor and do the focal radiation boost. But we're not there yet, of course. That's going to take some time. But we have it here already. So what does it mean for patients at UC San Diego? It means that we can take that same patient I showed you at the very beginning. We highlight the tumor. This is the radiation dose. So the blue is the dose, the high dose that we were trying to get. There's low dose out here as well. But the high dose, what I was intending to give, is right where I intended to give it. And the extra high dose is right on top of the tumor. So we have safe, effective, precise therapy, fewer men with a cancer recurrence, and fewer men with metastatic cancer. And with that, I would like to thank you for your time and also acknowledge it's a huge team of people helping to do this research. It's certainly not me by myself. And we do it with the support of funding from the National Institutes of Health, from the American Society of Radiation Oncology, the Prostate Cancer Foundation, and the Department of Defense. Thank you.
Nope, this is going all the way. Beginning. Sorry.
And in our hit parade, last but not least, we didn't do it, but we did the younger people first. So Carl and I are in the same group, so we'll end with the older group. And Carl is a professor in our department. He's the director of prostate care at California Proton Institute. He's an internationally recognized expert in prostate cancer. And often a doctor, when you go and see a doctor, they often say, oh, I am the most experienced in this or what, they just make up stuff like that. Carl actually gets the moniker of the most experienced because he treated the very first Loma Linda prostate cancer patient when he was in his training in 1990, over 30 years ago at Loma Linda. So there's a wonderful, I don't have the picture, Carl, you're gonna have to give me the picture sometime, of a young looking Carl in the room with the, where they're treating the first patient, because this is 33 years of experience in the field of proton therapy. So let's, now let's transition, hopefully the technology will work.
Gonna try. Let's see. Can you guys see my screen now?
Yes.
Can you hear me?
Yep, we can hear.
All right.
You.
Fantastic. I'm still laughing over that was a great intro. Yeah, I can't believe it's been 3 decades, but it has. So greetings to all from the Pacific Northwest, where it's a typical beautiful rainy and cloudy day, as you'd expect in January. And I'm going to give a hopefully brief update on the status of proton therapy and where some of the more interesting things that have happened in the last year or so. A lot of which has been covered. A lot of these breakthroughs they're not just unique to proton therapy. Realize that protons, as Dr. Mundt mentioned earlier, they're just one of the many modalities that we have to do radiation treatment. Yeah, it's a form of external beam radiation therapy. And we're blessed in San Diego and through UC San Diego that we have all these things to offer. And the job of the radiation oncologist, of course, is to pick what is best for the particular clinical situation, because it's not a one-size-fits-all. There are a lot of very good ways to treat prostate cancer. And it's our job to figure out what's best for the individual. So let me see if I can get my slideshow to work. There we go. This is what the public thinks of, right, when they think of radiation. My gosh, big bombs going off and casualties in the millions and things we hope that obviously we never lived to see. The target, when we do radiation therapy, any type of radiation, doesn't matter. Our target is about the opposite extreme in terms of size. Radiotherapy works by disrupting DNA, which is something which was not understood until the 1950s. We were doing radiotherapy before the turn of the 20th century, but it took another half a century to figure out how it actually worked. And what happens when you do ionizing radiation is that you break DNA chains. And if you create enough breaks, that DNA will not be repaired. I mean, this is happening to us every second of our lives naturally. We're all exposed to radiation throughout our lives, from cosmic rays to the radioactive material in the rocks, et cetera. And all life has evolved ways to repair this injury. We're fortunate in the world of radiotherapy that, by and large, malignant cells are less able to repair that damage and therefore more likely to die. And in the case of some particular cancer cells, that difference is profound, and we can give very low doses of radiation and cure people. Unfortunately, for most adult tumors, that difference in sensitivity is pretty dang modest. So we evolved all these technologies to try to be more specific as to where we put our dose to try to crack that therapeutic window open a little bit more. And we have some basic tenets in radiotherapy. These are the things they teach us as residents. The first thing is that when people tell you something is radiation resistant, well, no, it's not. It's just a question of how much dose you can give. You can kill anything, literally anything, any living system with enough radiation. Now, again, that's not impossible. The problem you run into is that you have to worry about the healthy tissue that's immediately adjacent to what you want to kill, and make sure that you don't give such high doses that you damage that. As I mentioned a minute ago, malignant cells have a somewhat limited ability to repair radiation damage. That's how we can kill them without hopefully killing you. And probably the more controversial point here is that we've been trying to figure out for a long time, is there a threshold dose? Is there a dose of radiotherapy or even a dose of radiation exposure below which damage and the risk of things like second malignancies do not occur? And it's debatable whether there is or not. At some point, you fall into the noise. But as a consequence of what we've learned the hard way over the last 100 years, we've come up with this principle called ALERA. We love acronyms, right? As low as reasonably achievable, which just means that when you're doing treatment or if you're doing diagnostic work with ionizing radiation, you should use as little radiation exposure to healthy tissue as you possibly can. And as all of our technologies get better, that becomes more feasible, not only in the therapy world, in the diagnostic world. The mammography has improved to where the doses are lower, et cetera. We do that and stand for safety. And if you look at all of our advances in radiotherapy technology, again, this has been touched on already today, they have been really stimulated by that idea that we need to limit dose to good stuff and increase dose to bad stuff. And that's everything that we do, whether it's intensity modulated X-ray therapy, particle therapy, implants, doing radioimmunotherapy. They're all different ways to do the same thing. They all have the same idea in mind. And this is largely, I think, it's a reflection of two things. It reflects our knowledge of physics, and it reflects our very limited knowledge of radiation biology. Remember, I said a minute ago, we didn't know for 50 plus years how radiation even killed cells. When you look at how we treat patients, we have all these different technological solutions in radiotherapy that are designed to, in essence, pull the physics lever. What can I do with modulating the intensity of my X-ray beam to spare healthy tissue? And how can I change my implant, et cetera? We haven't really developed ways yet to exploit the biology, the basic biology of the cell and how radiation affects it. That's an area that remains a frustrating, how's a bad sentence, but it's an area where we just haven't done very much. People have been, not from lack of trying, but the understanding remains poor. Now, Dr. Mundt mentioned earlier, and Dr. Rose, intensity modulated radiation therapy, intensity modulated X-ray therapy. This is, as it should be, the standard external beam radiation treatment that you're going to find hopefully around the world, certainly in the United States here in this part of the 21st century. And it's based upon doing things dynamically. You have some type of a 3D reconstruction of what you want to treat based on imaging, multimodality imaging, hopefully. And you modulate the intensity of the X-ray beams in real time, which allows you to deliver varying radiation doses to healthy tissue that the beam is passing through. And there are lots of different brand names of different machines that do this. People talk about, well, what's CyberKnife and TrueBeam and Halcyon and VMAT and all these other names. They're all variations of intensity modulated X-ray therapy. And so they're all employing X-rays to deliver their treatment. And we've had this now in general clinical use for just over 20 years. It's a technology that first came into being really in the late 1990s. And because it's a relatively straightforward adaptation of existing linear accelerators for X-ray therapy, it was widely adapted very, very, very quickly. And I do like to point out, especially to other radiation oncologists, because this comes up a lot, that we did not adopt this technology. It did not become our standard of care because we did a bunch of prospective phase 3 randomized trials against its predecessor, 3D conformal X-ray therapy, to see which one worked better in terms of toxicity and disease control. What we did instead as a radiation oncology community is we looked at our first principles, like I showed earlier. High dose to tumor, good. Dose to normal, lowering dose to normal tissue is also good. This technology let us do a better job of that than we could do in the past with its predecessor technologies, and that's why it was embraced widely, purely because of the superior physics. So with IMRT, what you're able to do is create these exquisite high dose areas like you're seeing here in the red on both of these panels. This is a prostate being treated with a couple of different variations of IMRT. Very, very highly conformal treatment because you have all these different beams coming in intersecting, or you're using a complete arc. The only potential downside, and it's a modest downside to doing this type of treatment with X-rays, is this dose bath. Right? It's the low dose to moderate dose areas that increase when you bring in more beams to get a nice, beautiful high dose area. And what we're talk about and worry about sometimes and debate about is what is the importance of this dose bath in terms of harm to the patient. And look, it certainly is not, again, the same for everyone. This dose bath is something that is likely far more critical in kids and in young adults, which is one of the reasons, for example, that protons are the treatment of choice in pediatric radiation oncology. It's probably not, it isn't nearly as important in those of us who are a little bit older. But ideally, if you didn't have to treat this normal tissue, you wouldn't. But current status of IMRT, again, it is the de facto standard of care, as it should be. It's an excellent treatment, good results, as good as anything else out there. Toxicity is very low. In the case of protons, as we're going to talk about here in a bit, the physics is superior, but the availability, unfortunately, this is changing, remains inferior because of the complexity and therefore the expense of the centers. Dr. Mundt showed a picture earlier of the size of some of our contemporary equipment. This mimics what X-ray therapy looked like back in the 1930s and 1940s. If you look at the history of X-ray therapy prior to World War II, there were a few centers in the United States that could do high energy, what they called it a high energy X-ray therapy, couple MeV X-rays, and the machines were literally 30, 40 feet tall because they were based upon Van de Graaff generators. The pictures are great. Based on these Van de Graaff generators to get that much power. And of course, over time, those things have become miniaturized. Thankfully, and not too surprisingly, that's where we're going in the proton world. And really what we need to do, I think, and we're getting there, is we've got to get to the point where either we can show that the dose that we're sparing the normal tissue spares the additional, is worth the additional cost of proton therapy, or we have to be able to deliver proton therapy for the same cost as intensity modulated X-ray therapy, in which case a lot of the arguments you currently see in the radiation oncology literature will disappear. So I think everybody in the audience knows what a proton is, subatomic particle, the most common particle in the universe, actually. It's the number of protons that in a nucleus which determine the physical property of an element, and they have a positive charge. The source that we use for protons in the proton facility is hydrogen gas. So we get the protons from the hydrogen gas. The reason that we like using particles for therapy is because of their physics, and specifically, unlike an X-ray beam, which completely traverses a patient, although it's attenuated, when you shoot electrically charged subatomic particles into things, what you get on the entrance side is a relatively low level of ionization. And this depends upon the medium that's going through and the energy of the beam, but eventually, as the particle begins to run out of kinetic energy, you start to get an increase in ionization. And in the last few centimeters of travel, you get this big spike of dose, which is usually about 4 times the dose on the entrance side. And then once you get to here, the particles run out of kinetic energy and the dose drops to 0. And this august-looking gentleman here, William Bragg, he discovered this in 1904, 1903, when he was shooting alpha particles into a water tank in Adelaide, Australia. And he measured this. And it was one of the many things he discovered in his physics lab. Like a lot of these guys, William Bragg, typical underachiever, he and his son were the 1915 recipients of the Nobel Prize in Physics for other things they did, for developing the science of what we now call X-ray crystallography. But he discovered this, and okay, great, people understood why it happened, but its practical uses seemed elusive at best at that point. By the by, that this is a facility that's being built nearly complete now in Adelaide, which is the first Australian Proton Center, which they have named after him, and I'm hoping to be seeing it here at some point in the not too distant future. But for 40 plus years, there was no practical application of the Bragg peak until this gentleman, another underachiever and somebody I was fortunate enough to meet at Loma Linda many times and I really admire, Robert Wilson, wrote a paper back in July 1946, which said in essence, hey, maybe that Bragg peak would have some interesting clinical applications in real life situations. He gave the example in his paper of treating brain tumors and not having to treat through the head. He was born in a town called Frontier, Wyoming. It's not made up. That's where it was. He got his PhD at Berkeley. He was a graduate student with Ernest Lawrence, Nobel laureate, inventor of the cyclotron. He went on, as you'll see here, to become the youngest director of any experimental division at the Manhattan Project. His job was to develop electromagnetic separation of U-235 and U-230 from 238. So most of the uranium that was used for Little Boy, the first combat atomic bomb, was produced under his tutelage. And after the war, he went back into academia. And in the mid-1970s, he became the founding director of what is the United States' premier high-energy physics laboratory, the Enrico Fermi National Accelerator Laboratory out in Batavia, Illinois. In addition to being a physicist, he was an architect and a sculptor. He designed the headquarters building here, which you see in the Fermilab symbol. It's a 16-story building, which is now called Wilson Hall. It's modeled on one of the famous, I think, your cathedral in Louvain, if I'm saying that right. And he did these multi-ton sculptures that are around the grounds at Fermilab. And he and his wife were actually buried there. Again, just a fascinating man. So he writes this paper in 1946, and then 8 years later, almost simultaneously at Berkeley and the Harvard Cyclotron Lab, they first started doing human treatments. And you can see how the setups slightly differ from what we would consider to be reasonable in modern radiation therapy. But remember, from 1954 until 1990, and there were thousands of patients treated with protons over that time span, everybody was being treated in a physics lab. That's where you found the machines that could accelerate particles to proper velocity. So if you needed particle therapy, you went to Lawrence Berkeley Lab, and if you were lucky to be one of the 3 or 4 people that could treat a day, that was it. These were never facilities that were designed for human treatment. They were very cleverly adapted to treat people, but they were very, very, very suboptimal at it. You didn't have the ability to image easily. You didn't have patients fixed in one position with the machine rotating. All the things that we normally do, we take for granted in the radiotherapy world, you couldn't do at the time. So beginning in the early 1980s, Dr. James Slater, who's here on the far right at Loma Linda, pretty much made it his mission to get a medical proton center built. This had been tried at a few other bigger academic centers, and everybody, of course, was told, no, you couldn't do it. And Dr. James Slater, who another person I quite admire, was one of these gentlemen who just wouldn't take no for an answer. He figured out how to get it done. No one's going to build you the equipment. So Now, as Dr. Mundt mentioned earlier, the Department of Defense does a lot of good stuff in radiation therapy and research. Dr. Slater was able to get the Department of Defense to give the Department of Energy a grant to build the equipment, because the equipment was built at Fermilab. It didn't hurt that this gentleman here, Jerry Lewis, was the local congressman who was in favor of it, and it also didn't hurt that Robert Wilson was the director of Fermilab at that time, but that's where the machine came from. And fortunately, what we are seeing now is that the machines are getting to be much, much, much smaller, thankfully. On the left here is a typical schematic of a multi-room proton treatment center like ours in San Diego. You have one accelerator which serves multiple rooms. These gantries, in our case, they're 36 feet in diameter. They weigh 280 tons apiece. Big footprint, lots of expense. What you have now by a number of manufacturers are one-room facilities that, this shows a tennis court, that much, much smaller in scale. And some of these now actually everything fits into one room. So as a consequence, the cost is going down, which means more and more facilities can employ this. And I'll show you a map on that in a second. The other thing that's changed is the delivery method. All modern centers use what's called pencil beam scanning, where effectively what you're doing is 3D printing with protons. You're painting the target electromagnetically. You're putting in protons in layers that are millimeter thick, and you use that to build up these exquisite doses around in your target, which also allows you to do cool things like what Dr. Seibert was showing, where you're doing a boost to areas within the prostate or anything else that you want to give a higher dose to. So as of today, we have over 40 operating centers in the U.S. A number of existing facilities have either upgraded or expanded. For example, UPenn, University of Pennsylvania, now has 3 proton centers, and MD Anderson's building a new center. Part this is because they need more capability, in part because some of the older centers have had to retrofit so they can do pencil beam scanning. We are getting more and more volumetric imaging, the same type of imaging that we have in the X-ray world, in the proton world, so that we are able to image the patients in near real time for positioning. There are 18 plus centers under construction in the country, and probably the biggest change that's happened is that the majority of these are now 1 to 2 rooms. They're much smaller, like I showed you a few slides back, and they're much less expensive. They're still not cheap, but the prices have come to the point where it's not something that requires $100 million, $200 million to do it. You can do it for $20, $25 million or even less. I've seen quotes of $10 million for one room. In the last 3 months, for example, Stanford and Moffitt Cancer Center, which is at the University of South Florida, have signed contracts to build one-room facilities. And although it would be the subject of another talk, there is a carbon ion facility now under construction at Mayo Clinic in Jacksonville. So particle therapy is certainly not stagnant, it's moving on. And if you look at where the centers are, you can see the majority of them are clustered in the Midwest and East. In fact, most of the members of NCCN, the National Comprehensive Cancer Network Comprehensive Cancer Centers, either have a facility like UPenn or Johns Hopkins and Memorial Sloan Kettering, or they're in the process of building facilities like, for example, Ohio State. But there's still a paucity of facilities out here in the West. Hopefully that'll change more in the next couple of years. So we talk about prostate cancer. It's also something which has been treated with protons for a long time. The first patients that were ever treated were treated beginning in 1977 at the Harvard Cyclotron Lab. So yours truly was a freshman in high school at that point. And the first paper on this was published in the medical literature in 1979. Dr. Mundt and I would we look at the names on that paper, we recognize them. Bill Shipley and Joel Tepper and a few of the other greats in our field were on that paper. They were again using a machine that was never designed to treat people. So they had to come in with this beam that went right between the legs, and as a consequence, they treated a fair amount of rectum. However, they still showed it was feasible and that the toxicities were acceptable. As Dr. Mundt mentioned, Loma Linda, the first prostate cancer patient, was treated on October 8th, 1991, a day I remember quite well. That year we treated, between then and the end of the year, we treated a total of 3 prostate patients, the second of which, by the way, was the accelerator physicist who designed our machine, not Dr. Wilson, but one of his associates. And it's gone on from there, and worldwide now you've got 50 to 70,000, probably more than that, patients who've been treated in the U.S. and overseas for prostate cancer with protons. The planning and treatment and this, again, you've heard a lot about this today, as you should. For all modern radiotherapy, imaging is critical, but what's probably pushed this field along more than anything else have been imaging and fast computers. If you can see it, you can hit it. If you can't see it, you end up treating larger areas, treating more normal tissue, like we used to do, when we would literally draw on people's skin, or when I would draw on a piece of X-ray film with a grease pencil and say, yeah, the target's going to be in there somewhere. These are all complementary modalities. CT is good for certain things. Dr. Seibert's presentation on MRI is fantastic, showing you what that can delineate. We now have, in addition to that, PET CT with whether you're gallium-68 or fluorine-18. They're all synergistic. They all show you a little different picture, literally, pardon the pun, of what you want to treat, and you put them all together in your computer. You fuse all these image sets together, and you draw on one. You take the best aspects of them all to create your treatment plan. So again, you've seen this before. Here's the prostate on CT. It's very homogeneous. You can't tell where's cancer and where's benign prostate tissue. It's somewhere in there, but you don't really know. You start doing your standard MR, and you can see this is from a T2 weighted MR, and you can see areas that look suspicious. They look different than the rest of the prostate. That's what I'm outlining out here with the mouse arrow. I've got another blue arrow there pointing at it. This is another sequence that we use. That's called an apparent diffusion sequence, which I would look at as kind of a poor man's cousin to RSI imaging. But you put all that together and you get a target. Now, in the last couple of years, we've had functional imaging, right? The FDA approved F18 PYL back in May of 2021. Medicare started covering it within the next 6 months or so, which is pretty amazing for CMS. And the indications are changing. At the time it was approved initially, it was for patients who had suspected metastatic disease, suspected recurrence, et cetera. And now it's considered to be imaging that can be used in lieu of, not as complementary to, in lieu of staging imaging like MR and CT. It's an argument that I think that a lot of us have had with insurers lately, but that's the current position on this, and that's only going to improve. And we've been able to do this both at UC San Diego and at the Proton Center now for over a year, and it has been very, very useful in targeting. This is the kind of thing you see on PSMA PET. These are gallium images that I grabbed from the paper, but again, here's your CAT scan in the center. Well, where's the cancer? If you look at the image here on the right, you can see there's uptake in an area that otherwise looks normal. This unfortunate individual also has a couple of lymph nodes that are involved that you probably would not see if you didn't have this imaging to clue you into them. They're too small to stand out on standard imaging. And when you're doing a radiotherapy treatment plan, you can do things like this. So this is a fusion of a CT and a PSMA PET CT. In this gentleman's case, I'm going to be treating his lymph nodes electively. That's these pink volumes. But he has a PET positive lymph node up here in his external iliac. So I'm going to be giving this area a substantially higher radiation dose simply because I can identify that there is disease in that location, and higher doses will equate to better disease control. So protons, this is a typical proton plan treating the prostate with two lateral beams. You've got the gland here. This, by the way, is hydrogel. The reason that there's a hot spot here is because this is a patient where I am doing, as I try to do routinely, intraprostatic boosting to escalate the radiation dose within the prostate to areas that contain identifiable disease, because of the data from the FLAME trial and some other studies which have shown that this is beneficial. And if you look at a patient cut down the middle, right down the middle this way, same thing. You can see the prostate. You can see the areas around that where you're not treating. And there are a lot of areas that aren't receiving any dose at all because you're not having beams that completely traverse the patient. And that's really where I think protons have their advantage. In general, in the proton world, the larger the target you have to treat and the more irregular the shape of that target, the greater the disparity in dose. So if you're just treating the prostate, you've got all these good technologies that do it. You're going to have a very, very, very high dose of the prostate and low doses outside of it. If you have a patient that's more advanced disease where you're trying to treat, like in this case, the lymph nodes, which are kind of a H-shaped distribution, and they go for quite a distance from the prostate gland, You can certainly cover that with modern X-ray therapy, but you end up giving more of a dose bath to the patient. So what this means acutely during treatment is that these gentlemen tend to have more diarrhea and fatigue. Now, most of them get over that, not a problem, but if you didn't have to do that, you wouldn't. And if the two machines were sitting side by side and access wasn't an issue and cost wasn't an issue, I think you would be hard-pressed to want to treat more normal tissue if you didn't have to. You would use the technique that treats less normal tissue. So again, the bigger the field, the funnier the shape, the more complex the shape, the greater that advantage. For treating the prostate itself, if there's an advantage with protons, it's pretty modest. It's not, modern X-ray therapy is good stuff. But as those fields get bigger and more regular, that's where you see differences. So I'm going to touch very briefly on some recently published data. This is about a year old, 2 years old. University of Florida, a little bit older than that, looking at patients that were treated with older proton techniques that they compared to patients they had treated at their institution with IMRT over the same time period. The radiation doses were roughly the same. The IMRT patients received a little bit less radiation. Median follow-ups were roughly equivalent. Both groups of patients got hormonal therapy, but there was a different percentage between the two groups. The cohort study, it's not a prospective randomized trial, but it doesn't mean we can't learn from it. So the first thing they found was that if you talk about overall survival, they didn't see a difference if the patients were older. They did see a difference in recurrences and in disease-free survival with the patients who were younger than that. These numbers are good either way, 97% versus 90, this should be 91%, not a big difference, but still a little bit, it was statistically significant. For the intermediate risk patients, that difference existed, but it was a little bit less profound. The high risk patients, no different because they tended to fail in other parts of the body. They didn't see an increase in toxicity. In fact, they saw the opposite, though, in the proton patients, despite the fact they got a somewhat higher radiation dose. And again, these numbers are low either way, but still whatever you can do to minimize toxicity, whether it's gastrointestinal, like rectal bleeding, or genitourinary, makes sense. And their conclusion was that the freedom from relapse rates in the proton patients for these subgroups, low and intermediate risk, were lower than with IMRT, despite the fact that the IMRT patients received more EDT and for a longer duration, and they had a lower toxicity in the proton patients despite the higher median dose. Same thing, we looked at this just acutely during treatment. This is from an ongoing trial called the PCG registry trial, where in essence we just looked at patients receiving either protons or IMRT for locally advanced, big fields. Now we're treating the pelvis. Acutely means during treatment and for a short time thereafter. Not too surprisingly, the patients who had the pelvises treated with protons, not the P's in that sentence, tolerated treatment a little better. They had less acute GI toxicity than with IMRT, although this washed out over time. So it wasn't something that persisted for years after treatment, but during treatment, they had a little easier experience of it. And probably the last thing I want to touch on, which I think is most interesting, and I had mentioned this last year, was a paper that was looking at risk of radiation-induced cancer, right? That's one thing we never want to see. And that's always a concern with radiation treatment, especially in kids and young adults, but even in, more senior adults, it's a worry. So this was a big review. I was looking at the National Cancer Database, 9 million patients treated over a significant time period, and it looked at different ways of doing external beam radiation, whether it was 3D conformal, what we did in the past, IMRT, which is our current standard, or proton treatment, had to have a minimum of 2-year follow-up. Most of the patients, not surprisingly, were treated with X-ray therapy. That's what you'd expect because of the much greater availability. And they did the best they could to compare the incidence of second cancers in between these different radiotherapy modalities. And the first thing they noticed was that despite what had been predicted, there was no difference in that second cancer rate between doing 3D conformal, which was the standard of the 90s, and treating more normal tissue, and IMRT. However, when you look at those similar patients treated with protons, the incidence of second cancer is quite a bit lower, about less than 1/3 the rate, which is not too surprising because this matched it up very nicely with mathematical models that have predicted we would see this rate. And interestingly, it wasn't just a one-off finding. They found it in 9 out of the 10 common adult cancers they looked at. The only area where they didn't see it was in lung cancer, probably because of the poor survival. Again, as I mentioned a minute ago, this was very consistent with mathematical modeling, and the importance of that is that the mathematical models it was looking at are the basis of our radiotherapy protective regulations that we use today. So when people will often tell me, radiation oncology, well, that's based on a model, I'll say, yeah, it's the same model that you're using, which is determine what your exposure limit is, what your patients can get when they get diagnostic studies, and why you have X feet of concrete in your building. It's not just some fairy tale model. It's a model that's based on human data, and we have validated it. And this was just a scatter plot they did of odds ratio, but you could see for virtually everything that we talked about, with the exception of lung cancer, there was a lower risk of second cancer in the proton patients. Not a surprise, you're treating less tissue in total, you're giving less radiation in total to that normal tissue. Now, the FLAME trial has been talked about. I think it's fantastic. It's very exciting. I'm going to go through pretty quickly because I think you've gotten a good background on it, but this is exactly what we want to continue to do. I have been doing intraprostatic boosting of the proton in the proton patients that I treat for prostate cancer for several years now. I have been consistently changing that technique as data like this comes out, not only for the dose you want to give, but how to minimize toxicity. But it is, the better we get with our imaging, the better we're going to be able to do this, and also the better understanding we have of what determines toxicity, like urethral dose and rectal wall dose, the better we're going to know how to protect those structures and keep them from being hurt by our treatment. Yeah, again, Tyler showed all these excellent data. It's paper, it's well worth reading. So in conclusion, I still have physicians who should know better tell me, oh, it's experimental, and I'll remind them that we've been doing this since the Eisenhower administration, and that we started treating prostate cancer, during the Carter administration, actually long before IMRT came on the scene. So that is just a statement people make out of either ignorance or malice. I'm not sure which. As the equipment becomes less expensive, we're going to see more of this. And again, this just mimics the history of radiation therapy in general. We've gone from one machine to another, based on physics, improved physics, and then we build lots of these, and the costs come down. And we need to get, I think, to stop a lot of these, I think are kind of ridiculous arguments, we have to get to the point, and we're getting there, to where the cost to the person who's writing the check for the treatment is no different. If insurers don't, they quibble when you charge them more for something if they don't see a value in it. And by the way, when you talk about second cancers in adults, most insurers kind of turn a blind eye to it. In my experience, what they usually will tell me is something to the effect that, well, and we worry about what can happen up to 12 months after treatment. You ask them why, because it's kind of shocking, and they'll tell you, it's because we have a lot of patient turnover. We have 5 years, 50% of our patients are another insurance company or a Medicare or stuff, so they're pretty happy to kick that down the road. Someone has to pay for it, but when you get to the point where there isn't any difference in the cost of the treatment to the insurer, they don't care what you do. They tell you do whatever you think is medically indicated. So where protons have a potential advantage, in certain cases we have a decreased instance of GI toxicity, less bone marrow suppression in some cases because we're treating less healthy tissue. There was a paper showing that in the prostate patients, we do not suppress testosterone production in the testicles because of the scatter dose there. And that we, as I showed you, have a lower incidence of second cancers, which is low with X-ray therapy. Please don't take that incorrectly. With modern X-ray therapy, that incidence is still low. And it's certainly been an exciting field to work in for the last, can't believe it, 3 decades. And I'm quite fortunate to have lucked into it, which is exactly what happened. I ended up doing my training at Loma Linda because I wanted to come back to California, and I just happened to get there when they were digging the hole for this big thing called a proton center. So thank you for your attention. This was a picture, by the way, yesterday of something that's good to see in California, snow. These are not the Sierras. These are actually the Trinity Alps, which are in the northwestern part of the state. You can see the Pacific Ocean out there. That's out there by Arcata. It was a beautiful day to fly. Thank you very much.
So, Carl, if you could stay on the line, it would be helpful. But there's one announcement.
Yeah. Before we go to some questions from the audience, I do want to share the fact that the UCSD is having a prostate cancer patient summit. That's 1 week from today at the location down at Park and Market downtown. I will try to get the, I apologize, I did not get the details up on the website yet, but I will be doing that imminently. It's going to be a big event with a lot of exhibitors, a lot of information available, and we'll try to be there as well. I've kind of sat on this, forgetting about it since I got COVID in the middle of hearing about it, so. But yeah, go ahead.
Yeah, so we went a little long, so the meeting is officially over at noon. So if you want to leave, we're gonna stay for a bit and answer questions and everything, but just realize that no offense because you expected noon, so we went a little long. So is that?
It's
I'm gonna stay, and if Tyler, you can stay a bit. A little bit, and Carl, you're a captive audience on the phone. Dr. Rose has promised that he would take his son to his basketball game, so he's going to have to leave. Can you stay for one question?
Sure.
One question. He works for me, so he's stuck with that one.
One directed just to Dr. Rose.
We'll do one.
Dr. Rose, thank you. My question is a simple one. You mentioned in your talk about, as a consumer, taking time to understand your cancer, and you mentioned 3 types of doctors who would be good to have working with you: a urologist, a radiation oncologist, and a third physician. And I didn't get the third physician's name.
Yeah, it's a medical oncologist, sometimes also called a hemonc doctor. Not everyone needs a medical oncologist, but often they're the ones that would give hormonal therapies or the more advanced hormonal therapies or even chemotherapies sometimes, and is involved in the newer treatments like Pluvicto and things like that. So the very earliest cancers maybe don't necessarily need a medical oncologist, but even then it's kind of nice to get a third opinion, because the surgeon will probably tell you that you should have a surgery, and the radiation oncologist will probably tell you you should have radiation, whereas the medical oncologist can sort of help you put that in context a little bit too. So it's a nice person to add on the team.
Thanks. And before they all got to take off, once again, a big round of applause for all the doctors. All right. Thanks a lot. Next question, please.
My name is Jay Keys. Last year, Dr. Eich and Dr. Rossi gave me 39 sessions of proton therapy. For the last 8 months, my PSA has been undetectable. But I'm just worried that potentially there's some hidden stealth prostate cancer that could be hiding out in my bones or lymph nodes or someplace that's not generating the PSA that I'm seeing with my monthly blood tests. At what point do I ask for some sort of a scan, like a PSMA PET scan or a CT scan, to confirm in my mind that the PSA that I'm reading says undetectable really means I don't have prostate cancer coming alive back in my body?
I'm going to have our imaging doctor do that one.
So generally, if you have intact or localized prostate cancer, and even when it starts to get somewhat regional, if the PSA is really low and has never risen on hormone therapy, then imaging is almost certainly going to be negative. And the PSA has to really start to climb before you're going to see anything, even on the latest scans. So I don't think it would be reassuring. It would be a waste of your time. Unless your PSA is rising. There are exceptions. That would be somebody who I already know has metastatic disease, has been on therapy for like systemic, they've got bone metastases, they're on therapy, they've become castrate resistant, meaning that the cancer is growing despite being on hormone therapy. Then the imaging becomes more important independent of the PSA. But that's a nuanced situation. For the most part, PSA is low, scan's not going to be helpful at all.
Yes, I guess it's for everybody. Let's say, and I'll choose a number of PSA of 10. What's the difference between an Acumen scan, which indeed, in fact, I myself had and the Advantage, regular Advantage kind of, not the Medicare one, paid for. I couldn't believe it. But anyway, what do you see the peculiarities, let's say, let's say the PSA is 10 or greater, between an Acumen and pylorify.
Right now, we would prefer the Pylarify or PSMA as being the most sensitive, so the most likely to find something. But you know, these have not been very robustly studied against each other head to head, and probably won't be, because these are very expensive trials, and you have to have somebody who's interested in the result. And the people who have the money, i.e. the companies that make these tracers, stand only to lose. So like so right now I would say PSMA is our best. And then the next thing is make sure the person interpreting that PSMA scan is really good. And that's harder to figure out, but extremely important. I've seen many cases where you could have gone either way, and depending on who's actually looking at the images, you would have a completely different treatment decision.
You spell
Pylorify. And then the generic name was up on the, it's F18 or 18F DCPYL, I think it is. Anyway, PSMA is what matters, though. I don't think you need to worry too much that it's Pylarify. There's also a gallium-based one that's fine. It's just that Pylarify is the most common in the U.S.
Once someone has received a PSMA scan, how easy is it for us to say, get that imaging in our hands such that we could take it to somebody else for a second opinion or a second read?
Very easy to get the images in your hand. You just ask whoever took them then they legally have to give them to you. So they'll give you like a CD. Getting somebody else to read them is a little bit harder because the reimbursement is not so simple. So you can't just like send it to somebody other side of the country and say, can you read this? Because then they would just do that all day and never be paid for it, and they wouldn't have time to do the ones for their own institution. So challenging. But if you're seeing a physician for an opinion, like if you're seeing me for an opinion, then I will look at them, and if I think that I am concerned about the interpretation by the other doctor, then I would take them to somebody that I trust. But I wouldn't want people to hear that and then think, okay, everybody needs to go ask for a second opinion about images, because asking myself or Dr. Mundt to look at a Pylarify scan is not the best way to get the best opinion about a Pylarify scan. It's having the physician that does that do it. So asking us about treatment, and if we think that the imaging is changing our treatment decision, then we will investigate further.
And I think at UCSD, I think we trust you guys to read these types of scans. My cousin who just had prostate cancer in the middle of nowhere in Vermont, I was very concerned about him getting either a second opinion or stuff. But as it turns out, especially today with digital medical records, his file was reviewed by their cancer board, which even included all the way from Albany to Boston of experts. So it's like it's wonderful that we get that chance.
Yeah, so as we're asking the next question, remember there is a whole field of radiology, and a radiologist is a board-certified individual who reads radiology films. Radiation oncologists, like Carl and myself and Tyler and Brent, we use them. Tyler's a little different because he has a PhD in imaging and the development of imaging, but I think it's very important when you go to a surgeon and a radiation doctor, they're the one using the images, but the real expert in the imaging is a radiologist, and you often won't ever meet one because they're kind of behind the scenes, like a pathologist.
Right. And actually, to make it even more complicated, the PET scans are often read by a nuclear medicine physician who may or may not be also certified in radiology. So it's complicated.
Okay. For somebody with metastasized cancer to the bones and taking hormone therapy, is there some criteria for adding additional therapy besides hormone?
Yes, but I think that I think there are a lot of details that need to be worked out. So sometimes then radiation is useful, depending on the circumstances, and then there are also a whole slew of other therapies that are systemic that would be under the umbrella when Dr. Mundt was talking about different doctors. That would be with the medical oncologist.
When prostate cancer cells have spread to the bone or to lymph nodes, we're still monitoring with PSA. But what about when we're talking about bone cancer or cancer of lymph nodes or lymphomas or sarcomas that are not related to the prostate? Is it the same type of cancers we're talking about? Bone cancer versus bones that...
Well, prostate cancer that goes to the bones is not bone cancer. It's prostate cancer in the bones. So it's biologically a prostate cancer that makes PSA usually, and we can monitor it. People have bone cancers, very rarely, it's not compared to prostate cancer, does not have anything to do with PSA, and it has its own ways to
That was my
diagnose and
question,
treat.
but likewise with lymph nodes as well.
Yeah, you don't have a lymph node cancer, you have prostate cancer that's spread to the
Or
lymph node.
lymphomas, yeah. all
Yeah,
right.
lymphoma is the one that arises in lymph
Right.
nodes and bone marrow.
Thank you.
Yeah. Yeah, I want to, can we take a woman as, I like to show that we care about gender.
I was beginning to wonder about that. Thank you.
Ah,
If somebody recently had 43 radiation treatments.
yes,
And his cancer spread past the prostate, and this person was kind of over 80. So is that because you gave him less each time because he was a little older?
yeah. Well, there's different reasons. When I said that we're trying to go quicker into that 28 days, shorter days, when we treat bigger areas, like the lymph nodes and the pelvis, we can't squish it. So we have to go longer. And then we try to add these extra, what Dr. Rossi and Dr. Seibert were talking about, adding extra dose. There are technological ways that they both use to give it without even lengthening it further. But you can't, sometimes we have to go longer. But I think it's when you see a doctor and you say, you need 39, 43 or some high number, say, is there a way to go shorter? And sometimes there is, sometimes there's not. Okay.
Next question.
Sorry, I'm going to have to run. If there are any imaging questions, last one, I'll take it. But otherwise, I have to go also pick up a child.
The question I have may have something to do with imaging, which is we all hate the term salvage, but in a post-prostatectomy situation where you have a rising PSA, where is the technology going with respect to radiation therapies? And is imaging going to generate a circumstance where targeted therapies are more appropriate? You know, what's really going on with that?
Sure, I'll field that before I run, but I think that my colleagues also could. I mean, it's similar to what I was talking about with the PSA rising. If the PSA gets to some threshold, and people argue a little bit about it, but around 0.2 or so, because we don't generally, unless you have a lot of high-risk features, we don't generally anymore treat right away. We wait until your PSA gets to about 0.2 anyway. And at that point, then we would get a PSMA PET scan. And that's the most sensitive. It's the most likely to find something if something is visible. If we see something, then that would change how we, where we point the radiation, basically. If we don't see anything, then we presume that the cancer is most likely in the neighborhood of where the prostate cancer originally was, and we treat that region anyway.
Next question.
Thank you all.
So another example of the difference between Carl and I being in I'm in my 60s. Carl, I don't know if you're 60 yet, but
Just got there. I just got there, AJ. Yeah.
so Rose and Seibert have children they have to take to sports events, so they have to go. But we're older than this. So, but again, the meeting officially has ended. So I just want to make sure anyone who, if you have engagement, no one's offended. Carl and I will stay around for a bit and answer any residual questions. Is that okay, Gene?
Yep.
Okay.
Dr. Rossi, this question is directed at you. And I grew up in the Pacific Northwest, so I know what the weather's like this time of year, and I sympathize with you.
But I like it.
Yeah, as long as you don't have to go out inside in it. But anyway, the question is, after completion of proton therapy for prostate cancer, There's two questions. What is the normal hormone therapy time that somebody is on? The second question is, if you've had both hips replaced, can you have proton therapy for your prostate? I've been told yes, and I've been told no.
That's got to be frustrating. Okay, I'm happy to answer both of those in turn. So the use of hormonal therapy and the duration of hormonal therapy is identical whether a patient is treated with any of these forms of radiation treatment. We do it in protons, we do it in X-rays as an adjuvant to make the cancer cells more susceptible to the effects of radiation. And the duration that is used is really dependent upon the risk group that the individual is in. In general, what you're looking at for the patients who are in what's called the unfavorable intermediate risk group is that they're typically given hormonal therapy with any of these radiotherapy techniques for a total duration of between 4 to 6 months. So they actually start hormonal therapy, and then at least in the U.S., we usually begin radiation treatment after they've been on hormonal therapy for around 2 months. So if we're treating for 5 weeks, they're going to be on hormonal therapy 2 months before, a month and a half during, and then anywhere from another half a month to a couple of months afterward with any radiotherapy. With higher risk patients, the duration of hormone therapy that's currently recommended is quite a bit longer. And if you look at the most recent guidelines on this, it's between 18 to 36 months in total. Same thing, you start a person on it, you do the radiotherapy relatively early on, beginning about 2 months after hormonal therapy was started, and then you continue it for a long time afterwards. So the duration of hormonal treatment is determined not by the radiotherapy modality per se, it's determined by the type of prostate cancer that was present. In terms of can you or can you not treat with bilateral artificial hips, the answer, at least at our facility, is yes, you can. The biggest issue in the past with bilateral artificial hips has been the imaging. And back in the day when the imaging that we were using was CT only, and that's all we had really for a couple of decades. With bilateral artificial hips, you get a tremendous amount of artifact on the CT image. In effect, you have shadows because the X-rays are attenuated as they go through the hips. So you'd have this black void where the prostate was. So where is it? You don't know. You end up drawing something that you think is the prostate in those cases. And you look at the plan and say, this plan isn't any better than it would be with X-rays where you're going to be treating a similar volume. What's changed over time, of course, is the technology. First of all, MRI is now available, which can give you prostate images that you otherwise would not have. And this is also a case where I often would do functional imaging with PET to further help delineate the target. But even in the CT world, the CT manufacturers have developed software that can subtract out that artifact, that can take care of it. So you're able to, even on the CT scan, see things that you couldn't see in the past. So I've been very comfortable in San Diego with treating bilateral artificial hips. We figure out angles that do not go through the hips. And the most important thing, of course, is that we can image the patient and see that we are hitting the target. Some other proton centers, based on their institutional experience or in essence what they're institutionally willing to do, I'm comfortable with it. I know at Loma Linda, we didn't like doing it because we were based doing CT imagery and the image quality was relatively poor. But even some of the more sophisticated centers like Mayo Clinic in Scottsdale, they just feel as an institution that they're not as comfortable in that situation, so they decline it. But we can do it.
I had a question on your comment about radiation damage to the cancer cells as the DNA, which I think means that they don't croak until they try and divide. But what about immediate damage to cells? What about cells who are damaged such that they can't continue to live?
There is some of that, but the primary mechanism of action is that DNA damage, which is something that is not expressed until that cell attempts to replicate. So you're absolutely right. A lot of these cells don't croak until they attempt to go through a cell division or two. Yeah, and in the case of prostate cancer, that can be a couple hundred days even.
Yeah, and they don't all divide at the same time either.
No.
There's some evidence that possibly when you give the treatment over a few days with a really high dose, that SBRT, that we might be using some other ways to kill a cell than just DNA damage. So that could be the membrane of a cell gets hurt and different things, but once you start giving a lot of radiation at one time, it sort of changes the rules. But predominantly, we're a DNA damage group. Protons and photons do damage to the DNA a little differently, but that's a mechanism for both of them, predominantly.
Doc, I have a question. Is HIFU part of proton?
What's that?
HIFU.
HIFU is a different thing.
It's a different subject.
Yeah, high-intensity focused ultrasound is HIFU. And so that's a use of ultrasound to treat, you know, in conjunction with MRI usually, Carl, isn't it? But it's not a radiation technique.
Yeah.
Sure.
It's another focal technique for treating parts of the prostate.
First, thank you for this meeting. I've had prostate cancer now for 22 years, okay? And this meeting's made me feel wonderfully stupid, okay? But two little questions. Does UCSD have that LU 177? You know that new drug, LU 177?
We just started that.
You do have it, okay. I would just, and then the other comments you made about the prostate cancer cells get into the bones and it's not bone cancer, it's prostate cancer. What do they do, like dig in or something? What happens?
Yeah, you can think they're a foreign object and they're in there and they're damaging the bone.
Okay.
And they can break the bone. They can do a lot of bad things to the bone.
Thank you.
Hi, Dr. Rossi.
Yeah.
Are you still doing the 5-year follow-up after treatment? And if one missed the 5th year due to COVID, is it still worth scheduling that 5th year?
Yeah, short answer is yes and yes. And the follow-up doesn't stop at 5 years either. What happens after 5 years is if the PSAs have been low and stable, then I typically will change the duration between assays. I'll go to once a year. But yeah, if you miss the year because of COVID or for some other reason, you still need to be checked.
Okay, thank you.
The good news is that the government, Medicare, your providers are allowing a lot more with the telemedicine visits because of COVID. So we can do a lot more as doctors via phone and video than we could ever do before. That was not a legal way to do things. If you're seeing a patient, you couldn't do it on video until COVID. It's one of the few things that COVID has helped, I think, medicine. Everything else has hurt.
It's Jay again. Another question, this time for Dr. Rossi. Thank you for the 39 fractions of proton therapy last year. It seems to have done the trick for me, but I am having one side effect. I know I could expect GI and GU side effects, but they've been very, very minimal. But the one side effect, which kind of surprised me, I wasn't aware that might be caused by proton therapy, was chronic fatigue. I was kind of blaming it on Lupron and abiraterone and my age, as opposed to blaming it on anything that might have happened when we did my lymph nodes.
I would continue to blame it on Lupron and abiraterone because you generally will get chronic fatigue from hormonal therapy, and it can persist for months to even years after hormone therapy has been completed. In general, with radiation therapy, the amount of fatigue that you create during treatment is directly proportional to the total volume of tissue that you're treating. And of course, that shouldn't persist after treatment. So I would look at the hormonal therapy, unfortunately, as being the culprit.
All right. One last question here, and then we'll let the doctor go.
Okay. It appears that in this day and age, long-term cancer patients and that have had a lot of imaging, a lot of radiation treatment. Have you seen, oh, sorry, should I start over? Okay.
Yeah,
I
could you?
was saying that these days there are long-term cancer patients who've received a lot of radiation treatments and a lot of imaging as part of their diagnostic and so on. Is anyone looking at what your lifetime dose might be, and if you're getting close to that? And I presume that even if there is such a limit, you got to plow ahead anyway, because that's the only way to whack the cancer.
Yeah, so it's important to know about, sort of your lifetime and sort of the cumulative, amounts of radiation. That's super important when you're really young. Children, 5 years old is a very different story than treating a 55-year-old, because the risk of a long-term, they have a 70-something years that they have to worry about. When we're in our 50s, I'm in my 60s, 70s, it's a different story. It changes. And also, what are we doing? Are we treating one part of the body, or are we exposing the whole body? And so when we talk about lifetime risk and things, we often talk about astronauts and other things that their whole body is getting exposed to radiation. It's very different if we treat one part of the body. We can treat another part extremely safely. Even something nearby, protons can help sculpt away, the overlap. But it's this lifetime risk is a very different story. It's usually a total body risk. It's not a focal area risk. Because I have patients all the time that said, I was treated to the prostate, now I need something else in my body. And they go, am I over my limit? The answer is no. Well, there's a total body limit. Yeah.
I just have a quick question. I have moderate prostate cancer. I'm with I'm with Scripps.
Yeah.
How do I come see you or Dr. Rossi as a second opinion? Do I have to get my primary to refer that, or insurance, or can I just call you up and bring my checkbook, or what do I?
Well, there's different ways. Let's say you were at Sharp and you wanted to be seen at Scripps. Let's make it a little less, about this story. Some insurance plans allow that, some don't. There's the network. Some will allow like a second opinion only. So it's a story with the network and the insurance thing. Medicare and some of the other things. Medicare, if it's the primary, is agnostic. It sort of allows you to do, it's if there's a specific Medicare provider that's, let's say, contracted with whatever, St. Mary's of whatever, sometimes they're going to try to hold on to that. So I think it's talking with the group. Sometimes if it's only an opinion, they'll allow that. But if it's an expensive treatment or a surgery or something, often the insurers want to control where you can go.
But
the different types of Medicare, you're right.
So I could call your office and you would.
Yeah, we can find out. Our people can find out, and they can also advise you. They could say, they won't even allow a second opinion, or they will allow something or other. We can advise you on that. Yeah.
Yeah, that's the best thing to do, is that contact the offices directly, and then you can start working through the insurance issues and let you know what's feasible and what's not.
Yeah. And I think the important thing, for example, the proton world often is insurers give them a hard time. So people like Carl are very experienced about getting on a phone with an insurer and making a case. It's called, what's that called, Carl? The peer-to-peer. Peer-to-peer.
Peer-to-peer, yeah.
Yes. So it's something we do as doctors. Surgeons do it too for different surgeries. Medical oncologists do. The bone marrow transplant doctors are very good about getting on and doing these appeals. The important thing is insurance likes ask permission, not forgiveness. So do the upfront work of getting approvals. Don't do something, have a heart transplant, and then do the request to the payer, because they could drop you. That would be terrible. If you get the authorization in advance, it might take a lot of effort, but then have the surgery, that type of thing. So ask for permissions, not for forgiveness.
Very true.
All right. All right. Well, thank you very much, everyone. We'll still be around for more questions, one-on-one or chatting. So please enjoy some food and drink outside as well. No food or drink can come back into the auditorium. Thank you. Thanks once again to the doctors.
Thank you.